Good morning. I am Dr. Terry Thompson, Assistant Professor in the Department of Environmental Medicine and Public Health here at the Icahn School of Medicine at Mount Sinai. It's a privilege to serve as the Master of Ceremonies of the 5th Clinical Climate Change Conference organized by our Institute for Exposomic Research here at Mount Sinai. In addition to those in the room today, I want to welcome those watching from around the world. We have over 300 people registered with representation from across the globe and the US, as well as Canada, Brazil, Egypt, India, Mexico, South Korea, and more. This annual CME conference is designed to provide clinicians and trainees with news they can use, research updates, and evidence-based solutions that will help them improve their practice now and adapt it to better serve their patients. This year's theme is focused on worker health, as workers are on the front lines of the climate crisis, from delivery drivers to workers in healthcare, to farm workers. So many are at increased risk for accidents, illnesses, and injuries from climate-driven hazards, such as extreme heat, severe precipitation, hurricanes, floods, and wildfires. And at the same time, workers are our key to a resilient society at the front lines of a just transition and the creative solutions that will help us preserve and strengthen communities. I am proud to tell you that Mount Sinai is home to a division of occupational medicine that was the first hospital-based occupational health division in the country more than 60 years ago. Our state-funded Sokas Centers for Occupational Health have an interdisciplinary team of occupational medicine physicians, ergonomists, and industrial hygienists that provide specialized care for workers across sectors. Mount Sinai is also home to one of the federally funded World Trade Center program clinical centers of excellence that provides medical monitoring and treatment to those who responded in the aftermath of 9/11, weeks and days and months that follow. The magnitude of the climate crisis means that we must bring the expertise of occupational medicine to all medical specialties. Workers are coming through the ER to their primary care doctors, to mental health providers, and beyond. We must work across specialties to understand the health effects and the preventive steps to take to protect our workforce, their communities, and families. I'd like to take this opportunity to acknowledge my fellow conference planning committee members, Dr. Robert Wright, Dr. John Meyer, Dr. Emily Sinai, Dr. Perry Sheffield, Dr. Ismail Nabi, and my good friend, attorney Sara Zaat. I also want to acknowledge my colleagues at the Sokas Centers and the World Trade Center Health Program Clinical Center. Many of the providers were able to join us today, and we thank Dr. Michael Crane, who is the Clinical Medical Director, and Julia Nicola Burns for prioritizing this special event. I also want to thank the many supporting organizations, especially the American Lung Association and the New England Journal of Medicine. You will hear from Dr. Al Rizzo, Chief Medical Officer at the American Lung Association at noon, and also Dr. Karen Solomon, Deputy Editor of the New England Journal of Medicine, on the afternoon panel. However, before I introduce today's keynote, we have a few housekeeping notes. You should have received by email a link to the post-conference evaluation that must be completed to receive CMEs after the event is over. It's electronic and time-stamped, so please wait until the end of the conference to fill it out. Also, please note you received in writing the required conflicts of interest disclosures. Planners and presenters have no conflicts of interest. My job today is to keep you on time. In the interest of time, I will keep introductions short and refer you to longer bios, which you can access via the QR code in your program. We have timekeepers at the front and at the front of the room, and they will let each speaker know when they have 5 minutes remaining to finish their presentations. We've built in questions and answer time throughout the day to encourage audience participation. To those who are watching at home or in the office, please use the Q&A function, and we will kick off the question portion with questions from the webinar audience. I'd like to take this time to introduce Dr. John Howard. Dr. Howard is the director of the National Institutes for Occupational Safety and Health, or NIEHS, and the administrator of the World Trade Center Health Program in the U.S. Department of Health and Human Services. NIEHS has the mandate to assure safe and healthful working conditions in the United States. NIEHS was established in 1970. It is a research agency focused on the study of worker safety and health while empowering employers and employees and workers to create safe and healthy workplaces. Please welcome at this time, Dr. John Howard.
Thank you, Dr. Thompson. It's a pleasure for me to be here. Just want to do a little poll. How many of you have never worked for remuneration? That is getting money from somebody for a job. Anybody has never worked in their life? Well, I don't see any hands. So you're all workers. You're all workers. And I'm here to tell you about what we do for the US government. In terms of climate and climate change, the US government has 14 federal agencies that participate in conducting research in the area of climate and its effects. This is a fairly recent activity, not even 20 years old, but it's an activity that's extremely important to bring as much information that we have in the federal government to all of you. There have been 4 national climate assessments, large documents, multi-chapters, in which various aspects of climate-related issues are discussed, research is presented, and research gaps are identified, and analysis is done. The 5th assessment, which some of you may have participated in, a draft was published and comments were welcomed until January of this year. So hopefully we will see the 5th National Climate Assessment come out later this year. What's interesting, if you look at this picture from the 4th National Climate Assessment, and you can see the various populations that the climate assessment have identified as important: communities of color, older adults, low-income communities, and children. It all makes sense. But where is the little orange for workers? I don't see it on this diagram, and we don't see it in the 3 and even the 4th National Assessment. And the reason we don't is because we are part of a system that has not been fully integrated into climate assessment. The National Institute for Occupational Safety and Health that Dr. Thompson referred to is 52 years old, and we arise from the Occupational Safety and Health Act of 1970. And our purpose is to assure that all of you who are workers, every man and woman in the nation, has safe and healthful working conditions. To 1, preserve our human resources, the various economies that go on in every state and every municipality, all require productive workers, and you can't be productive if you're not safe and you're not healthy. So in that act, established the Occupational Safety and Health Administration, which primarily does standards and enforcement of those standards. And NIOSH participates in providing scientific research to OSHA to inform those standards. So we're a little different in terms of OSHA. OSHA is in the Department of Labor, and NIOSH is in the Department of Health and Human Services. We're actually a component of the Centers for Disease Control and Prevention, which is an interesting place to be, because one of the things that we do as part of CDC is to protect the health and safety of healthcare workers. And I bring that to your attention because we sit in a building with a lot of healthcare workers. So what we've done at NIOSH in order to wrangle, depending on your word, the future of work, which is changing rapidly in every occupation and in every industry sector. We have established a future of work initiative. And you can see here from this very busy slide, we've divided it up into futures associated with the workplace, futures associated with work itself, and futures associated with the workforce, and subdivided it and subdivided it and subdivided in order to create research opportunities for those in science, for those in this medical school, in this center, Selikoff Center, and in other centers throughout the United States, to be able to generate new research in occupational safety and health and transfer that research into practice. And one way that we're doing that, in order to encompass all the expanding aspects of the future of work, is we've established, if you will, an integrated way to do that. And we call it total worker health. The idea that anything that's associated with the safety, health, and well-being of workers, we claim as a topic for research. And that's where you can find climate-associated issues within our Future of Work initiative and within our approach to total worker health. Now, I think you've all understood, or else you wouldn't be here, those types of things that you hear about all the time in terms of climate. Weather extremes and temperature extremes and rising sea levels and heat-related illness and all sorts of other things that impact human health as a population, as a total population. But remember, our interest at NIOSH is just in the occupational aspects. So even though this kind of a diagram subsumes all of the issues that we're interested in, we drill down a little deeper. As Dr. Thompson says, with regard to outdoor workers, why are workers at risk from the effects of climate and extreme weather? Well, they're more likely and greater exposure to these elements that we just saw. And they're not free to avoid those exposures because they have to work in those aspects. Whether you see somebody digging a hole outside of this building in August in New York when the humidity is 99 and the temperature is 99, or you see them in a field somewhere in Bangladesh. When you do any kind of medicine and you interact with any kind of patient, if you don't ask them, what's your job? You're not doing your job. Because to do a work history is to put that person in a social milieu in which you understand what the exposures are coming from work. So if you're filling out that electronic health record and you're treating this individual for asthma, and it's not getting any better, and you never asked what they were exposed to, and you find out they were exposed to isocyanates in their manufacturing plant, which is a known irritant for asthma, you have failed in your job. So occupational categories and these examples that I'm showing you here are the exposure issues that we need to pay attention to. And in terms of occupational health equity, we try to, in occupational medicine, to combine the work history with some of the other social factors that are associated with the particular job or the particular industry or subsector that they happen to be in terms of assessing their susceptibility for higher rates of injury or illness or specific rates of injuries and illnesses that other non-workers in that particular industry may have. So when we look very broadly at the climate factors that are really associated with occupational medicine, there are at least 8 or 9. And what I've reduced them to here is a short little visit that we're going to make to ambient temperature, to air pollution, to UV radiation, to extreme weather events, to vector-borne diseases and expanded habitats for those vectors, to industrial transitions that we're involved in. Again, asking the individual, do you work on top of a windmill? Changes in the built environment that we were seeing. So when we look at climate, we have to look at work exposures first, and then we have to relate them to the safety and health effects. So these issues are paramount. If you ask nothing else, ask questions about these types of work exposures. So I think the most common thing you hear about in terms of climate change is increased ambient temperature. You know, that's probably very common. But what you don't probably hear about is a worldwide epidemic, an occupational medicine epidemic, a nephrology epidemic. We're seeing significant increases in chronic kidney disease in outdoor workers. And Dr. Sokas is going to go into more detail, but this may be the first epidemic which is truly a climate change epidemic. Second leading cause of death among men in El Salvador. Young men of working age, 20,000 estimated, died. Farmers, sugarcane workers, construction workers, rice, corn farmers, cotton plantation miners, all of these occupational exposures, all of these occupations are at risk. And you look at the countries from Sri Lanka to India to Dubai, Egypt, Central America, Honduras, Thailand. What's causing this? Not 100% clear. Dehydration, certainly, heat stress, causing dehydration, causing kidney injury. But we don't know the answer. But you may see one of these individuals who worked in one of those countries come to you here at Mount Sinai or at your hospital with that kind of history. Increased air pollution. We see that as another issue. And clearly there's lots of studies looking at the relationship between air pollution in the increasing climate changes and the various levels of respiratory irritation and illness, whether it be asthma, whether it be COPD, and other types of issues. Clearly, the length and the severity of the pollen season is one issue that you need to keep in mind. And the impact on workers from air pollution is still, much research needs to be done. But generally speaking, we're looking at effects that are respiratory. Again, they help you explain the patient's clinical situation when you're talking to them and they're referencing respiratory complaints. Ultraviolet radiation. This issue of the mantle of greenhouse gases and the various gaps in the ozone layer that we've heard about for years that are closing and opening, These result in skin cancer, damage to the retina, immune suppression. Again, this is another climate-related issue that has clinical consequences. Ultraviolet radiation, and here I use the example of a particular type of occupation. If you will see a pilot, a flight attendant in your clinical practice, and they may have ocular issues, they may have cancer issues. The idea of UV radiation increasing, and certainly these folks spend most of their time at greater than 10,000 feet above the surface of the earth. Clearly an occupational history that you need to take. And again, as Dr. Thompson says, extreme weather, we all hear about it. That's the thing we focus on. It's on the news all the time. And clearly, whether it's a storm, a flood, a drought, a wildfire, the wildfires going on in Canada right now that are supposed to bring smoke and increase pollution to New York City area. These are clearly fatal events and near fatal events. And we all know first responders, the people that go out in response to one of these types of disasters, they need your help too, because they're workers that need specialized care, both before they go out, so they're prepared, while they're responding, and even after their response. Dr. Thompson referred to the World Trade Center health program, which I administer, 130,000 members throughout the United States that were exposed during a first response. And we're taking care of them 20 some years later. Clearly, first responders to extreme weather events, to other types of disasters are an important clinical issue. And another one that we often don't think about, except we can get bit by a mosquito or a snake or a poisonous lizard. Believe me, there are such things. And for those of you to think that rattlesnakes are not moving north or Lyme isn't moving south, clearly there are a lot of vector-borne diseases that are undergoing research now by infectious disease physicians that are saying, look, things are changing. The number of counties that are at high risk for Lyme disease increased by 320% in the last 20 years. So these vector things are changing. I raised the issue of reptiles because snakes that were confined to the Mojave Desert in California, the Sonora Desert in Mexico, they're moving north too. Temperature changes their habitat. Another issue that we don't think about in terms of climate effects are the industrial transitions that are going on now. And some of you are aware of renewable energy sources like solar and wind and biodiesel, nuclear and hydrogen issues. But there are workers who work in each of those subsectors, and their risks vary depending on the subsector that they're in. So if you happen to be one of the workers that work with wind turbines, you end up falling off a wind turbine. Well, we all know that construction workers are at risk of falls. That is the number one cause of death in construction workers. But we often don't think about people climbing to the top of a wind turbine being injured by working there. And even in our own environment, clearly as temperature increases, the demand for controlling the interior environment of a building increases. Increased filtration, we learned that during COVID-19 with HEPA filters, increased dilution ventilation with increased air changes per hour. All of those kinds of things are affected in terms of how our buildings are built, in terms of affecting also human health. So clearly at NIEHS, we have a lot of things to do, and we have separated both our own activities as well as the activities that we recommend for everyone who's doing research in this area, is to have a research plan, increase your surveillance about all of these issues, understand where the risks lie in terms of risk assessment, and what are the risk management, the control strategies that you can do as a preventive medicine aspect to control exposures to workers so they do not suffer clinically. And clearly, identifying the indicators of climate effects on workers is number one. We've gone through a few, but it isn't exhaustive. Determine the interactions between climate effects and work hazards, because we don't understand those interactions very well to date. And investigating what hazard controls work and which ones don't, because industry is not going to spend money on things that aren't going to work, and it needs scientific basis in terms of intervention effectiveness to determine that. And identify the most vulnerable workers, and certainly there are a lot of inequities associated in this area. For those of you who are interested in that area of research, there is plenty to do, because the most vulnerable in terms of all the issues that I have said this morning are workers who are those that are marginalized in terms of race, ethnicity, gender, national origin, and socioeconomic status. So our activities, I think, are basically trying to tie together existing 52 years of research to the next 52 years. And clearly, we're beginning to do that in many different areas, trying to develop strategic plans in that, working with other agencies, our sister agency at CDC, the National Center for Environmental Health, and also within our own backyard. We have centers for agricultural safety and health throughout the United States. And we're working with those specifically on the outdoor worker, the agricultural worker that Dr. Thompson mentioned earlier. So I thank you very much, and happy to answer any questions you have. I've included a massive bibliography if you want to become a student in this area. So thank you very much.
I would like to invite you to join me in questions and answers for Dr. Howard, question and answer session for Dr. Howard. So at this time, we will take questions initially from the online. Okay, all right. Seems like we already have some questions from online. Dr. Howard, I'd like to ask you, are there any lessons from historic issues that occupational health has encountered and innovated around that could inform how we as a broader clinical community prepare and adapt to the changing climate?
Yes, clearly, when you look at the essence of occupational environmental medicine, it's taking the environment of the individual, whether it be a general population person or whether it be a worker, and looking at that environment and the various exposures that are around there. So throughout environmental health and safety and occupational health and safety, there's been a number of issues that are extremely important. I will use the example of New York City, since we're in New York City, and I will take you back to September 11th, 2001, which was an environmental disaster in one aspect. The entire environment was toxic, and there were workers within it, not just first responders, but also other types of workers who were in buildings. And if you look at pictures from that time, you see them covered with dust. That dust was filled with 286 carcinogens, causing all sorts of different types of cancer. So we don't have to go very far in any kind of situation that's environmental or occupational, and we see the milieu, the environment itself, is the important issue.
Okay. Question from online. question is, should frontline workers' definitions include school, childcare, and other employees?
Yes, yes, ma'am, or yes, sir. Whoever asked that question. It's a fabulous question because it illustrates the issue that I brought up at the beginning. Everybody's a worker. Now, there may be a few in the United States that have never worked and will never work, okay? But even those folks, as well as everyone who works, is exposed to an environment that they cannot escape. None of us can escape it. And if you're in a school, there are issues that are exposure issues that are related to the school environment. One of the issues I'll tell you is schools are often built in the wrong place. And underneath a school is a former gas station or a toxic dump. And you have those issues. If you are a worker as a school teacher, and you're in a school that has a high risk of violence, either from the neighborhood or from the classroom itself, then you're a worker that is at risk of workplace violence. So wherever the worker is found, you look at that environment to see where are the exposures, and are any of those exposures hazardous to the worker? And then, because this is preventive medicine, occupational medicine, environmental medicine are preventive medicine subspecialties, what can I do to prevent that worker from suffering any harm from that risk? And we go through it whether you see occupational medicine or not. All the conversations that are going on in school districts about how to harden a school, all of that is basically occupational health, because we're trying to prevent the workers in that workplace from harm.
I have a question. We know that communities of color are disproportionately affected by climate change, and that historical and ongoing systemic discrimination and racism have resulted in the concentration of environmental harmful exposures in these communities. Can you talk about the burdens on workers in communities of color and how NIEHS is working to identify and address these challenges?
Thank you. This is extremely important. And I had just one slide on occupational health equity. We have had a program for many, many years. We've called it various things: special populations, vulnerable workers, and now we have a large umbrella under health equity. And we're actually funding investigator-initiated research in this area. So I hope all of you who are researchers who are listening will pay attention to our funding mechanisms that make that available. We're trying to expand our scope of research in this area of health equity. Certainly the premise, Dr. Thompson, of which your question is based, clearly a lot of environmental hazards are those that affect minority and disadvantaged communities. Everyone knows that. But oftentimes we don't think about the health equity issues involved in the worker population. And that, I think, is something that we all in research, and we're seeing it, no matter whether you're looking at an NIH study or a NIOSH study or a National Science Foundation study, we're starting to see the federal space develop more energy, also in terms of research monies, but more research in the area of health equity and these differential effects that we see. So when you look at populations and you look at the general CDC literature on all of these populations, you see the equity difference. You see the inequities in whatever it is. It's blood pressure, it's mortality, infant mortality, whatever you look at, you see these inequities. Our job in the federal space is to pay more attention to these activities, to fund more research in this area, to be able to get rid of these inequities, and certainly to get rid of the underlying issues.
Thank you. We have one last question, and this comes from the online. What would you like to see in medical education to address the challenges facing workers, particularly as it relates to climate change?
Well, that's an easy answer, and I will turn to my colleague, Dr. Sokas, who's going to speak next. I think both of us would say more education about occupational and environmental medicine, I include them both, at the earliest stage in medical education, whether it be the first year, the second year, wherever you put it, so that people are aware of these issues, so they don't come to a conference and go, what the heck is NIEHS and what the heck is occupational medicine? So I think if we could do that in every medical school across the United States, and every nursing school across the United States, and every respiratory technician school, and any healthcare worker, so they know when they see a human being in front of them, they ask, what kind of work do you do?
Okay, we have one other question from the audience. Please identify yourself before answering your question.
No
Thank
problem. Hi, thank you so much, Dr. Howard, for your talk. My name is Zoe Laskris, and I'm here from the Barry Commoner Center at Queens College. I'm not a clinician, I'm an epidemiologist, and but I think this question could be relevant for everyone. Something I'm grappling with often is that a lot of the climate change related health effects, it's very hard to identify the cause as climate change, especially for somebody who doesn't know somebody's entire work history, like you were talking about. One problem that I'm finding in my own research as I go through workers' compensation claims of heat-related illness, almost every cause is listed as not otherwise classifiable. So I'm wondering what advice you have on the surveillance front and helping to identify the burden of climate change related health effects among workers in terms of helping us identify the cause, put it somewhere down on paper so we can try to get a better grasp of the gravity of this problem. Thank you.
Oh, a fabulous question. I give you A+ for the question, and I have no answer for you at all. Because this is your problem. You are the epidemiologist, and epidemiology teases out causation, correlation too, but we hope for causation eventually. But clearly, we don't have the surveillance data available to you. You pointed out the worker comp data and the fact that it doesn't give you that much granularity in terms of understanding what was the exposure that caused the heat. I think that really is a charge for epidemiology to be able to figure out how do we better understand surveillance data? How do we improve it so we can get at least the rudimentary data that an epidemiologist can use to be able to then classify why this individual developed a particular type of climate change effect. So what you raise is the future. We have to solve that. If we're going to do serious climate-related research for the environment or occupational medicine, whatever, we're going to do those kind of studies. We're going to have to improve the epidemiological profile of the data so that people like you can grab it and say, I can do a study of that. It's a challenge. I don't have the answer, but that's an area that I think people like you need to say, I want some research dollars to be able to figure that question out. Not to do the study, but to actually figure out the methodology and epidemiology that I can get at answering that question. Even give me a head start. So what's the methodology? What do we have to change? And I think interfacing with that example that you gave with the worker comp community, I think would be the first step to be able to reach out to those types of meetings and say, hey, you guys are not doing your data well enough for me to figure this out. Fabulous question, fabulous challenge, and I wish you a lot of luck.
Thank you. Let's thank Dr. Howard for this round of applause. Thank you very much.
Next, I would like to introduce Dr. Rosemary Sokas. Dr. Sokas is professor in the Department of Human Science at the Georgetown University School of Health. Please hold your questions for Dr. Sokas until the 11 o'clock panel discussion. Okay.
Thank you. And I just need the clicker. Clicker.
Yes.
Thank you. Thanks, Dr. Thompson. Thank you to each person in this audience, to the conference organizers, and to everybody remotely
It's a privilege for me to be here with you. I'm going to start talking about in detail the heat exposure that Dr. Howard and Dr. Thompson have both mentioned. I'm going to focus pretty much exclusively on workers, but there's some general areas of health disparities that are really important, and they are important for workers as well, including some of the long-term outcomes that you've heard Dr. Howard just describe, which are emerging. These are pieces of information that we didn't really have a few years ago. We'll talk a little bit about prevention at the end, and I'm not going to mention the fact that when the heat rises, traumatic injuries also go up among workers, and that when heat rises, there are physiologic changes that take place that reduce worker productivity. These are both important areas that we just don't have time to cover. This is a lovely graph that Dr. Jonathan Patz put together based on WHO data. And if you look at it, it not only shows those areas of the world that are responsible for producing the greenhouse gases that have fueled global climate change, but also the countries and the regions of the world that have not. And you'll see there's some pretty thin spaces in terms of where you haven't had exposure. This, on the flip side, is the graph, is the map of where the countries are experiencing the worst mortality, the worst outcomes from all of the different causes that you just heard Dr. Howard describe. So disparities are baked into global climate change worldwide and within the United States. And I just want to take a couple of minutes to talk about what's going on in the United States as a legacy of structural racism. You're all familiar with the Homeowners Loan Corporation, which was a quasi-governmental organization set up in the 30s to tell banks which neighborhoods they should loan to, they should issue loans to. And this particular paper is very interesting. They do beautiful graphics, which I'm borrowing, but they're focused on air pollution. Again, one of the things you just heard about, but you know that tree canopy is not only associated with reducing air pollution, but also obviously the summer urban heat island effect. And so this is a map of Milwaukee in 1938, and there are 4 different homeowner loan corporation categories, from green, which is good, to red, which is bad. This is where redlining gets its name, and it's explicitly racist. It talks about the number of African Americans living in an area and the number of immigrants living in an area as what qualifies people for becoming a redlined area. And then decades later, what they did, they took satellite imagery to look at tree canopy across the 200 plus cities that were redlined in this way. And on the y-axis at the top and on the bottom, both y-axis, shows you the proportion of tree canopy. And you can see according to the category, if you're green, you've got a fair amount of tree category. It goes down step by step until you're in a redlined area. And this was taken in, this is based on data from 2001. Unfortunately, in 2011, on the bottom graph, you see the same thing taking place. So structural racism has an impact. This shows you the impact of urban heat island effects, summer urban heat island effects across, just separate study, 175 cities across the United States. Across the x-axis, you're going to see the increase in temperature from the summer urban heat island effect. The top picture is the blue represents non-Hispanic whites. The red are people of color, racial and ethnic minorities. The second one shows the difference between people who are at 200% or above the federal poverty level. The red are people of below the federal poverty level. And the third shows you the overlap between racial and ethnic minorities and people living below 200% of the poverty level. Then below that, the next two are kind of interesting. Again, you heard about the differences in age because it affects your ability to thermoregulate. So very young, very old, at risk. So when you look at people above the age of 65 compared to everybody else, you don't really see much. You look at people below the age of 5 compared to everybody else, you don't see a whole lot. You reintroduce race and ethnicity, and then you see the differences. So in the bottom, you see non-Hispanic whites over the age of 65 versus people of color. And then you'll see non-Hispanic whites under the age of 5 versus people of color. So heat exposure is fundamentally racialized in the broadest sense in the United States. Now, we all have our heat balance. We know that this is a combination of your metabolic rate, which can be changed by different conditions. Pregnancy being one of them will raise your temperature already. Work has a huge, and what we're focusing on. So sedentary work versus light work versus heavy, exhausting construction or agricultural work. But work has a big part to play in it. Heat is transferred through convection through the air. It's also, you have heat that comes from radiation sources, mostly the sun, of course, but also indoor radiant heat sources. And then we evaporate through our sweat in order to try to reduce some of that. So heat balance is really a combination of different factors. Only the first two listed here, the humidity and the air temperature, are covered in the heat index, which is mostly what you'll see posted and most of what people have access to. But if you really want to know wind velocity and radiant exposure, radiant heat, all of which are important for workers, then you need a wet bulb globe temperature, which the industrial hygienists do. And then other factors which aren't measured really are skin temperature and clothing. So clothing is something you can advise your patients on if they're working outdoors. Heat acclimatization, huge. Physiologic changes that take place, it increases your amount of sweat, it reduces the salt in the sweat, it changes your stroke volume and your heart rate. It's your thermoregulatory mechanism for adapting over time to hotter temperatures. And obviously you can go beyond this, but the lack of acclimatization is the reason heat waves are so lethal. And it's also the reason the OSHA data shows that among people who have heat stroke on the job, more than half occurs in the first 3 days on the job. So important to remember, you need to have heat acclimatization. You have to work while you're being exposed to the heat, but in a gradual increase. So 20% of your workload the first day, this is a rule of thumb, 40% the second day, you increase by the first week, you're pretty much acclimatized. By 2 weeks, you're acclimatized. You don't lose that acclimatization if you take a rest break in air conditioning or if you sleep in air conditioning overnight. In fact, these are really helpful things to prevent chronic heat from building up, heat reactions from building up. But if you're away from the workplace for a week or two, you can lose that acclimatization and you have to start all over again. So heat stroke, everybody here needs to know heat stroke. We all do know it. We know acute diseases include skin rash, heat cramps, syncope. Heat syncope gets people's attention. Those are all pretty self-limited, but you start to tell people, really pay attention because now you know you're in heat. And heat exhaustion, you're starting to raise your core temperature. Now, athletes will do this all the time. And in fact, people working will be raising their core temperature. But heat exhaustion is when you've got the headache, the fatigue, maybe some nausea. You tell your patients, listen, this is your body telling you, take a rest break, go in the shade, drink some water. You should be drinking water throughout the day, small amounts, but have cool water with you if you're working outdoors, because you do not want heat stroke. Heat stroke is a potentially lethal disease. It is immediately dangerous. You have to have immediate first aid response. Throw somebody in ice water. You're not worried about how fast you're worried about getting it done quickly. There's no risk to doing it quickly. And people need to recognize heat stroke. So there's classic heat stroke where you're hot and dry, which is heat stroke. That's it. You ice bath with definitive care. But you can be still sweating and have heat stroke. You can be soaked from prior sweating. So the real important distinction is central nervous system dysfunction. And that manifests itself at first just with confusion. So somebody on the job starts acting funny. He's a little confused. He might not, be making a whole lot of sense. He might be walking a little funny. That's heat stroke. That is heat stroke in the presence of heat. You get that person immediately into first aid and to definitive care, because I'm sure those of you who've been through heat waves as house officers or in clinical settings know this is not a good way to go. If you're, and the risk is huge, it's real, and it's multi-organ failure, it's coagulopathies. It is a terrible way to go. Now, you've heard Dr. Howard talk about the chronic information, which is just really emerging. We know a few other things. There's some other areas I'm going to share with you, including that prior heat stroke may shorten your life expectancy, but also it definitely makes you more at risk for the next episode of heat stroke. All right, we know about heat stroke. The elite athletes will be training with all kinds of physiologic monitoring, and they can actually raise their temperature sometimes, but it's in very carefully controlled conditions when they're getting ready for the Summer Olympics and all of that. Every year at the Boston Marathon, and I'm assuming in other marathons that take place, there are a number of people who develop heat stroke. In the Boston Marathon, they're people under the age of 30, and they're almost at the end of the run. So these are people really pushing themselves. And a number of them just get better with the first aid treatment and don't even need to be hospitalized. So the same is true for the military. The military has a lot of healthy young people. They used to, now healthy young people is not a total prevention. And you'll hear these tragic cases of some poor high school kid who's trying out for the football team in August who dies from heat stroke. So you can be healthy and young and still die from heat stroke if you push yourself. The military used to lose recruits fairly routinely from that until they decided they were going to stop doing that and figure out how to prevent it. So they flipped the training sessions. We'll talk about that in prevention a little bit more. Age extremes, you know about. The general population is at more risk because of that and underlying conditions. We have a lot of information from the MOccH, from heat waves and those sorts of things. And again, to get back to workers, really who we're focusing on today, they bring with them age extremes, right? So the average worker in the United States is now 42 years old. That's true in construction. And in many outdoor work settings, you've got people over 50, over 60 still working. You have, and Dr. Howard mentioned miners. The deeper you go into the earth, the more problems with higher temperatures that you get. So they've been studied for a long time. And then indoor workers. But even your postal delivery person, if they're in a heat wave, not in an air-conditioned van, there have been cases of fatal heat stroke among people just in any kind of outdoor work, basically. All right, so now we'll focus a little bit on the construction workers. Between 1992 and 2016, the proportion of the workforce represented by construction workers was 6%, but they experienced 36% of the fatal heat stroke deaths on the job. The bars just show the numbers. If we had rates, the number 3 there, the agricultural workers would actually be top because their rates are actually even higher. It's just that the number of workers is smaller in agriculture. So within, sort of drilling down within the construction workforce, African-American workers and Latino workers have twice the risk of fatal heat strokes. Now, this is because of where they work and the kinds of work they do. And so the construction laborers, the helpers, even within this high-risk group, have the higher risks. Roofers have higher risks even. And then the brick and stonemasons, because they're working so hard, have very high risks. So these are within a high-risk group, the highest risks. And this is just a disturbing graph from that paper, because what it shows is from 92 to 2016, those black dots pretty tightly correlate with the lighter dots, which are the black dots, the fatalities. The lighter dots are the average summer temperatures, and you see both of these rising in lockstep, basically. So this is a growing problem in the United States. And again, we talked about workers bringing with them all of their underlying conditions. We also have the climate that's increasing, and there's some debate about at what temperature do we really start to pay close attention. We all know that there are absolute levels beyond which you don't want to have people working, but we really don't pay attention to that much in this country. There are other countries where they'll shut down work between, certain hours. Heat waves we've talked about. There's different ways of categorizing them, probably one of the smoothest is you take the minimum and maximum temperature. If it's above 90th percentile for 3 days running, that's when you start to see mortality spiking. And so that's a heat wave definition. So if you're working during a heat wave, if you're working in the sunlight, this used to be called sunstroke. And if you're working in personal protective equipment, think about the wildland firefighters doing their jobs. Think about the person who's on a bridge trying to get the lead paint off in a Tyvek suit. So these are all things that will increase risk. And then it's everything people bring to the table. Obesity, that's half our patients. Tremendous numbers of chronic diseases will predispose to heat stroke, diabetes, cardiovascular disease, hypertension, right? A lot of neurologic diseases will do it as well. But if you're up all night with an acute gastroenteritis, you're going to be at higher risk the next day. If you're trying to work through a fever, you're going to be at higher risk. So all these things matter if you've had, and then again, if you're not acclimatized and if you've had a prior heat stroke. But then there's the huge list of drugs and medications that predispose. And this will link you to the paper that describes that in fuller detail, and also has references to the military, because they're the ones who are really paying the most attention. So you tell your patient, listen, you can't have, if you're outdoors working, you don't want to have alcohol, you don't want to have opioids, you don't want to have any substances of abuse. Those are all associated. Cocaine, you don't even need heat to get heat stroke, for crying out loud. So don't do it. The other things though, antihistamines. Who would think? So antihistamines, ACE inhibitors, beta blockers, I mean, a lot of stuff we treat people with are on that list. And you can't tell people, listen, don't go to work, you're not medically cleared, because they got to put food on the table. And again, disproportionately impacting low-income workers. So you say to them, listen to your body, pay attention, bring water with you if it's not supplied on the job, look for shade, rest. Don't be the one who has to show off. No John Henryism here. Don't be the one who has to be, the first day on the job, show how well you can do it. You work into it. Now, this is some of the data on this is data on mortality. So this is CDC data since the 70s. The orange bars are the mortality where the death certificate lists heat as the underlying cause. In the mid-90s, they started adding also when heat was included as a contributing factor in the death certificate. And then there's this really interesting study out of British Columbia so 2 years ago, they had that awful heat wave. During the period of that heat wave, they almost doubled their mortality. The number of deaths was close to twice what it would have been. So they took those deaths and compared them to an average of the previous 5 years during that time period when there was no extreme heat event. And they looked at their death certificates, which are always kind of messy, right? So their death certificates that say, and they had death certificates that they attributed the death to heat, death certificates where they said it was not heat related, and then there's this big pending pile, mostly because it's off waiting for tox. So they took those 3 different categories and they looked and they showed during the heat event, the odds ratio went way up for schizophrenia, also for diabetes, also for depression, and also for chronic kidney disease. Then they looked at the people who were supposedly not related to heat during that time. The death was not attributed. And it was up also for schizophrenia, also for chronic kidney disease, but this time you had ischemic strokes and ischemic heart disease elevated, significant. And then for the pending pile, it was schizophrenia, drugs of substance abuse disorder, and COPD. So some of this could be the underlying condition, some of it could be the medications people take for the condition, or the behavior that the condition is associated with. So then if you really want to do epidemiology, you move to Taiwan, because in Taiwan, they have pretty much every hospitalization, almost a huge number of data points from virtually all the hospitalizations are in a big data set. And between 2000 and 2013, they took 5% of those people and linked their charts over time so you could follow them over time. And this research group said, well, let's look at cardiovascular disease. So we'll look for people who are hospitalized with heat stroke, with heat-related illness. Now, remember, if you're in the hospital for heat-related illness, that's pretty bad illness, so that's close to heat stroke, and controls. And we'll look for people who didn't have previous cardiovascular disease, and we'll match them for age and sex and comorbidities that could be leading to it. And lo and behold, they find a stepwise increase in incident cardiovascular disease over the subsequent time period, in ischemic stroke, and then they weren't looking for this, but the chronic kidney disease. And this is just across the x-axis, the number of years follow-up. The y-axis is the cumulative cardiovascular disease incidence. And you can see across the bottom what you see in the general population, but then way up there, big difference, people who've survived heat illness and then heat stroke. So then they said, oh, this kidney disease looks like it's something popping up here. So let's look at the same population, same study group. And this time they merged people who survived heat stroke with heat illness prevention because they were close. And they said, okay, we're going to exclude people with prior kidney disease this time, age match 1 to 4 now with controls, and sex match, and look for any comorbidities, diabetes, hypertension, you match on those. And so what they found was a statistically significant increase in incident chronic kidney disease across the heat illness population, as well as end-stage renal disease. And this is what the graph looks like. And as Dr. Howard said, these authors have basically said, listen, this is the first global epidemic that's emerging from the global climate change. All right, so how do we prevent stuff? Well, people know how to prevent this stuff. It's not like it's a mystery. In a very high functioning organization, big multinational company that adheres to some international voluntary standards, the ISO standards, they do a really good job. They have medical clearance, they have medical and physiologic monitoring, they have industrial hygiene that does the wet bulb globe temperature, and then engineering controls where you air condition places or you wall off the heat sources. Or interesting stuff, you have a safety helmet that's got a cooling mechanism in it. Now, again, you want to see some of this tried out in practice and see what people, if they'll wear it or not. You don't want to get, ice headaches or whatever. But, so there's a lot of effort going in to protecting people. The same is true for elite athletes. The same is true in the military. So there's a lot of administrative controls. You don't have people work out in the direct sunlight. You change the work rest cycles. You have climatization that you're serious about. And then you have a lot of training for the workers and for their supervisors. And then you have really good first aid and really good medical care. And this is just a real quick look at global data from all active military personnel between 2017 and 2021. And these are all the cases of the numbers of heat stroke cases. Only the top blue bars got hospitalized. The rest were treated either first aid or out of the hospital. And those numbers are not climbing. Those numbers are flat, and they're trying desperately to get them down. So they've done a really good job with heat stroke. The question now remains, what's going to happen with these people, 20 years from now, 10 years from now? Are they going to have other problems? So now that's the chronic worry. So what are we doing for workers in the US? Not really a lot. I mean, there's tons of guidance out there. There's just not very many regulations. Now, the president has said that OSHA should establish a heat illness prevention standard, but there are so many constraints placed on OSHA rulemaking that that's going to take years. So they're working on it. They really have tried to fast track it, but it's going to be hard. In the meantime, OSHA, the employers in the United States have a general duty to protect workers from known recognized serious hazards. And so OSHA can cite on a general duty clause, but the courts have not always upheld them. And so that's a little bit harder for them to actually do. There was actually a case that got tossed out where OSHA cited an employer for having a 60-year-old roofer who died on the first day of he got heat stroke on the first day of the job. It took him 2 weeks to die, but because he was not trained, he was given a little bit of water and told he could take breaks, but there was no program in place, and that got tossed out. So these general duty citations are hard. I'm going to get a little into the weeds with OSHA here. There are state plan, there's federal OSHA. Half the states have a state plan OSHA. Federal OSHA can only regulate the private employees. It can't regulate municipal or state workers because it's a constitution thing. So about half the states will have their own state plan. New York is interesting. New York has a federal OSHA for private employees, but it has its own state plan for municipal and state public employees. So, so you guys are covered in the room at least. The 5 minutes. Okay, great. Some of these states have really done well. So California 10 years ago put in its own heat illness prevention standard for outdoor workers, adding indoor workers this year. Oregon, Washington State did the same thing. Minnesota, go figure, has one for indoor workers. And Maryland was told by its state assembly to get on the stick, but they're still kind of dragging their feet. Virginia tried and failed. But Colorado, which is a federal plan state, the legislature said, this is ridiculous, at least water rests shade. So, okay. So as a little shout out to New York again, Letitia James, God bless her, is one of the attorneys general who is calling, trying to petition OSHA to do an emergency temporary standard, which they did for COVID. But, you know, Public Citizen tried this a couple of years ago and it failed. So they could just kind of dismiss that. So the challenges in the US, if you've heard from Dr. Howard and from Dr. Thompson, we have undocumented workers who are working in the shadows many times. We have people who in the United States alone among high income countries, we have no job security. It's at will employment unless you're a tenured faculty or, you know, somebody in the government or in a union. But the regular people in the United States are, you know, can be told not to come back to work tomorrow, basically. They don't have paid sick leave, and so they're very reluctant to kind of push this stuff. And piece rate makes it just that much worse. So people have tried to regulate. The regulations all include really good information about how much water the employer should provide, what temperature, how much per person. There should be shaded areas for rest. Where they fall down is, it's like they don't want to decrease productivity. So they say, oh, 10 minutes rest at the end of 2 hours is as much work rest cycle as they'll get to. And for acclimatization, it's just have, you know, the supervisor watch the new guy. And there's no medical, forget medical. I mean, it's like, they don't even talk about it. So there are things that we need to do. What can you do in the meantime with your patients? You basically tell them, listen, this is a serious hazard. You want to take care, pay attention to your body. If you're having symptoms of heat exhaustion, fatigue, headache, nausea, you're in the sun, get out of the sun, and be drinking small amounts of water all day long, but stay in that shade and rest until you're feeling better, because you do not want heat stroke. And if somebody else on the job starts talking funny, then that's a 911 emergency. You get that person taken care of. But you want to have, and people can, you know, wear light colored clothing, make sure if they can have hats with brims and that sort of stuff. I mean, the usual stuff that you would tell anybody who's walking outside, but these are people who are going to be outside for 8 hours a day. So there's a lot of information out there, guidance information. There's a heat app. NIEHS and OSHA put out tons of information. These are links to just some of those pieces of information, including specifically for construction workers. So I'll stop there. Thank you. Okay, thank you.
Again, let's thank Dr. Sokas for that outstanding talk. Okay, we will now take a break. And I'm very gracious, so I'm gonna give you an extra 5 minutes. I'm just that type of guy, okay? So we'd like for you to return at 10:40. Now we're going to start at 10:40. Okay, so please be in your seats at 10:40. Thank you. Okay, for this next speaker, I work really hard to make sure that students and trainees, postdocs in our department have a voice. Our next speaker, Sara Zaat, is a medical student here at Mount Sinai, and she is not your average student. Sara earned a JD at Georgetown University Law Center, and at Mount Sinai, she co-leads the chapter of the Medical Students for a Sustainable Future. We're continuing on voices and counting on those voices, such as Sara's, to help us make those clinical policy connections. Let's welcome Sara.
Hi, everyone. Good morning. I'm Sara Zaat. Like Terry said, I'm a first-year medical student at Mount Sinai, and just last year I graduated from law school. And when I was in law school and decided to pursue a dual medical and legal path, the reason really is my passion about climate change and the environmental determinants of health. So I'm very grateful to have this opportunity to speak with you today about an area of policy that I'm very passionate about and hope to pursue for the rest of my career. And so I'm going to do an overview of just federal level policy developments relating to worker health during the past couple of years in the Biden administration. But of course, that's not to discount all of the work that's happening at the state and local levels too. So just to start, I don't have any disclosures for this presentation. And as a disclaimer, this isn't legal advice, and I'm not yet a licensed attorney. I passed the New York bar, but I'm still in the process of, thank you. But I'm still in the process of applying for my licensure. So there's a specific action that seems to have set off and set the tone for climate policy relating to worker health in the Biden administration. And that was Executive Order 14,008, called Tackling the Climate Crisis at Home and Abroad, which Biden signed at the very outset of his administration. And it calls for a lot of different climate and environmental justice related actions. So just to name a few of them, it calls for the establishment by agencies of climate action plans, which I'll talk about more. And it has various provisions specifically about empowering workers, including through creating job opportunities in infrastructure and conservation, investing in fossil fuel communities who could be left behind by a transition to a clean economy, and establishing a civilian climate corps initiative to support new workers in this conservation career space, just to name a few examples in this order. But to be clear, it doesn't provide funding for these initiatives, and it's kind of just a broad proclamation of what should be done. And there's also the creation of the Justice 40 initiative through this executive order, which basically means that 40% of federal funding for certain kinds of programs, including workforce development, must go toward benefiting the communities most impacted by environmental injustice. In terms of limitations of this order, like I said, it doesn't provide funding itself for new job creation. It doesn't create legally enforceable rights. And like any executive order, it can be revoked by the next president if they don't agree with the policy. And in some circumstances, an executive order could be revoked by Congress. So it has certain limitations, but creates this tone and sets off a series of actions by agencies in Congress relating to worker health. So to begin with, what agencies have done, I mentioned these climate adaptation and resilience plans. 23 agencies have established these. And just some examples of what has come out of these plans. There's now a $15 per hour minimum wage for federal wildland firefighters. And the US Department of Labor set up a climate adaptation plan committee to kind of coordinate activities within the Department of Labor, including OSHA's protection of workers from heat stress, which Dr. Sokas talked about. In terms of more details on the US Department of Labor's climate action plan, since that's one that would be more relevant to worker health, it sets out 5 priority adaptation actions, and for each action, there are goals, strategies, and timelines around that priority. And that covers various aspects of worker safety, making sure employees are properly paid and trained so that they can work safely, and other areas. And this is more upstream, but I thought it would be good to mention that this action plan also calls for protection of US Department of Labor facilities themselves, because the Department of Labor can't help workers in America if the facilities themselves are being compromised by the effects of climate change. So the plan also calls for protecting facilities from temperature changes, flooding, and other climate-related issues. Dr. Sokas talked a lot about this, but I also wanted to flag in terms of other Department of Labor action that OSHA created an instruction last year for a national emphasis program on various heat-related hazards, and that lays out a bunch of policies and procedures for both indoor and outdoor workplace inspections. So this is kind of an enforcement document. It's aimed at enforcement, but obviously there are still issues with getting compliance with protections for workers from heat stress. Department of Labor also responded to the Justice 40 initiative that I mentioned that came from the executive order by designating some of its existing programs for inclusion in the Justice 40 initiative. So now investment in these programs will go toward that goal of 40% of federal funding for workforce development and certain other programs going toward communities impacted by environmental injustice. So as I mentioned before, there's also this issue of fossil fuel communities possibly being left behind, and the executive order addresses this issue. Of course, there are still coal mining workers in this country. There's only about 50,000 left, but they're often clustered together in communities that depend on this business. So to address this, the Interagency Working Group on Coal and Power Communities and Economic Revitalization was established. And from that working group, they've issued a report to set goals to make sure to invest in job creation in these communities as we transition to a clean economy, which is another way to protect workers. So that's a lot of, or some of the agency actions that have taken place in this space. In terms of what Congress has done, I think the most notable, well-known example would be the Inflation Reduction Act, which was passed last year in August of 2022. It's a reconciliation bill, so it was easier to pass than a regular bill, that focuses on climate change and healthcare. I'll just talk about the climate change part. It's funded by taxes on corporations and more IRS enforcement of tax laws. On the climate change side, these are just some examples of what the bill does. It's enormous. It has tremendous funding within it. So this is just kind of an overview related to worker health. First, it establishes clean energy tax credits, which are linked to requirements that employers give their employees prevailing wages and proper training and apprenticeship, which helps them be able to feel confident in their work and know how to do it safely. And it provides funding for various other programs, not necessarily directly relating to worker health, but those programs include greenhouse gas reductions through carbon capture technologies, environmental and climate justice block grants, and there are specific provisions to protect people in Native American tribes as well. In terms of the impact of the IRA, an energy policy simulator found that up to 4,500 premature deaths and 119,000 asthma attacks each year can be prevented by the effects of the IRA. And a Blue-Green Alliance analysis found that because of the more than 100 climate, energy, and environmental investments in the IRA, 9 million jobs can be created by 2030. So in terms of key takeaways of this really big and complicated bill, it funds new and existing clean energy jobs. It's protecting public health, obviously, and investing in and supporting communities impacted by environmental injustice. But it doesn't do that much to directly address worker safety and health, aside from those clean energy tax credits that are tied to requirements that would protect employees. As for other federal legislation, there are there's a bill and another act that passed out there on the issue of worker health. The first is the Farm Workforce Modernization Act of 2021. It's just a bill. It's stuck in committee, but it addresses heat stress. It's a bill that focuses on migrant farm workers, and it would require certain employers to have protocols in place and training to protect their employees on farms from heat stress. But unfortunately, that bill hasn't become law yet. One that has become law, though, is the Infrastructure Investment and Jobs Act, which became law a couple of years ago. And it calls for safety guidelines for two kinds of workers, at least, telecommunication workers and workers who manage battery waste. And these are both industries that you can imagine being affected by climate change in terms of extreme weather, affecting telecommunication, and clean energy affecting battery waste. So to summarize most of the points that I've put out here, there's this timeline showing you how we went from this executive order at the beginning of the Biden administration to different legislative and agency action. The legislative actions are in blue, agencies in red. Something that I didn't include here, but is worth noting, is that we have a third branch of government, obviously the courts, and there is moving through the courts right now, although it's kind of at a standstill, a push for an implied right to a healthy environment. We don't have that in our Constitution, but people have been arguing that maybe we should have something like that. And that could, of course, have implications for arguing for the rights of workers in their environment to live healthfully. So where do we go from here on this timeline of action in worker health policy? Some recommendations that the Natural Resources Defense Council, which is an advocacy nonprofit, put together actually before the Biden administration, are, I think, really helpful in guiding policy still. These are like common sense aspects of worker health and actions that OSHA and other policymakers should take. Those are things that are laid out in more detail in the NRDC report. And this should guide really any further federal action going forward. The Center for American Progress also provided important policy guidelines in respect to implementing the IRA specifically, calling for, of course, like fair wages for workers, better safety and health standards, these things that the IRA itself doesn't exactly lay out, but need to be included in proper worker health-centered implementation of the plan. And so that's what policymakers can do, but it's not that they're the only ones acting here. Of course, we as future and current clinicians and researchers, et cetera, have a role at the federal level to influence policy and legislation and regulations. On regulations, you can comment on proposed rules on regulations.gov. Agencies are legally required to review and respond to significant comments. So at least in theory, you're not just speaking into the void at regulations.gov. You can advocate for bills you support relating to climate change and worker health. You can find them and track them on congress.gov. And you have a right to meet with your congressional representatives, usually just their staffers, who then should relay what you say to the representative. And that's something I've done numerous times in law school, as well as here at Mount Sinai once. It's easy enough to do, and it's a great way to get your voice heard and to start building a relationship with representatives if you haven't already. And if you establish enough of a relationship with representatives in Congress, really their staffers, they might be able to then invite you to, as an expert, to testify about your experiences at a hearing. And this isn't just a concept that exists, it really happens. For example, Dr. Caitlin Moretti delivered testimony just 2 months ago at a committee hearing on this kind of topic, health costs of climate change. So our voices in this area are really important and impactful. And so by getting ourselves more up to date on the policy, we can feel more comfortable engaging in advocacy around worker health at the federal level, which I hope everyone could try to do, because the more people speaking about this issue, the more likely we are to see advancement in the implementation of these policies to protect patients who are workers, which is probably all patients. And these next few slides are just my references. And thank you all so much for listening.
Thank you, Sara. We will now take questions from the online audience. Oh, okay. We also have some questions also. Can you talk, Sara, about your career path from law school to medical school? And where do you think you can have the most impact?
Right. So when I was in undergrad, I studied molecular environmental biology. So I was always interested in environmental studies and concerned about how I could have the most impact. And so I landed on law first and pursued environmental law in various ways in law school, and came to a point where I found that I was missing science and wanted to be able to actually have lived experience understanding what patients go through. I'm also passionate about healthcare, access to healthcare, and just being able to understand how that system works for patients. And I think that having that clinician perspective is really valuable in advocacy. So I wanted to be able to both advocate and treat patients in a complementary way. And that's what led me here. And in terms of having the most impact, I really think, taking steps like the ones that I mentioned, a couple of which, aside from testimony, I've participated in, are really important ways to just start getting used to the system if you haven't had that much exposure to it before, and getting your voice heard and sharing your expertise, which is something I hope to do as I learn even more about medicine and the healthcare system.
Another question came in from online. Do you need to be a physician to comment on legislation on Congress?
No. Anyone who is considered to have expertise and gets through the vetting process that they have on committees for selecting expert witnesses to give testimony can give expert testimony. And I actually shouldn't even just say expert in the traditional sense. Also, if you have lived experiences, people are asked to share their lived experiences in Congress as well. And those are equally important voices to be heard in shaping legislation. So there's a wide group of people who can give testimony. It's kind of just a matter of making yourself known to Congress.
One last question. Are there medical legal partnerships for low or no cost legal services co-located in health clinics that have models that are addressing sustainability or climate health risks?
Yes, and I can speak a little bit to my personal experiences in this. So I became familiar with medical legal partnerships while in law school, mostly on just on the policy level. So I didn't have much experience to the clinical side of a medical legal partnership until medical school. We have legal partners for the student-run free clinic called EHOP, or the East Harlem Health Outreach Partnership. And because of my background, I was interested in helping to update our list of screening questions for patients about the legal determinants of health that they have. And I also helped to update the procedure for getting them properly referred to our attorneys at Legal Health, which is part of NIEHS. That's our partnership. And some of the questions we ask patients about the legal determinants of health do pertain to sustainability and environmental health. Probably most notably, we ask about indoor air pollution like mold and whether they have adequate access to AC and heating. And those are the kinds of questions that become even more pressing and complicated with the effects of climate change, of course. So we are, in a way, monitoring the effects of climate change on patients' indoor environment, which could obviously affect their health as well. And aside from personal experience, there was a recent letter to the editor published in the journal Family Practice by a physician and an attorney on this very question, actually, of how MLPs medical legal partnerships can advance climate justice. And they talk about actions that have been done in Florida on this issue. A lot of interesting work, including relating to occupational health. Legal partners have put together letters of advocacy that physicians can use to advocate for their patients' employers to provide adequate cooling stations for them and rest time if they're working outdoors. That's just one example. There's various examples laid out in the letter to the editor, and I thought that was a really great example of how physicians and attorneys can work together to advance climate justice. And there's a lot more work to be done. And research on this issue, I think, would be really important. And that's what the authors of the letter said as well.
Okay. One more question, Attorney Zaat, that came in from online. Are there opportunities for early career students, doctors, and lawyers to get more involved in political affairs on these topics, especially those from more vulnerable backgrounds, positions with lived experiences, where such activities may cause friction with their work environments?
That's a really interesting question. I think what's implied there is that there could be a risk associated with engaging in advocacy, and that's absolutely true. In some ways, it's a privilege to put your perspective out there, and I think that certainly one way that I've been able to be involved as a group is, every time that I've met with staffers for congressional representatives has been as part of a group so far, and that's one way that you can be involved and share your perspective, but you don't necessarily have to share everything or be the person leading the discussion right away. And that would be one way to start getting involved and understand this space of basically you can just email the representative's scheduler, their staffer who's the scheduler, or you can fill out a form on their website to set up this kind of meeting. It's probably better to do it in a group capacity. And they should be able to meet with you. And it's a really impactful way to start building a relationship with representatives. But there's a lot to that question. And I think there's even more that should be done to create space for people whose voices really need to be heard more urgently in the climate justice space, certainly.
Okay, let's put our hands together and thank Dr. Zaat.
Thank you.
Now I'd like to introduce the next portion of our program. I'd like to introduce our panel on addressing the health needs of the toll worker in a transition and clean economy. Our panelists are Dr. Ismail Nabil. He is an associate professor, Department of Environmental Medicine and Public Health here at Mount Sinai. Dr. Nabil. You've already heard from our next panelist, Dr. Rosemary Sokas, who we heard from earlier. She is professor in the Department of Human Science at Georgetown University School of Health. And she's being escorted to the stage by one of our panelists also, Dr. Jasminka Golini Estradas, who is Senior Occupational Health Specialist, the World Bank Group. And last, our panel moderator, Dr. Emily Sinai, who is an associate professor, Department of Environmental Medicine and Public Health at the Icahn School of Medicine.
So much, Terry. I'm Dr. Emily Sinai. As you just mentioned, I'll be moderating this panel this morning. We're going to have some brief remarks from two of our panelists. Just a reminder that if you have questions from Dr. Sokas' earlier presentation, we will be addressing those here, so be sure to send those along both here in the audience and online. And so I will ask Dr. Nabil to give a short presentation, and that will be followed by Dr. Jasminka Golini Estradas.
Well, thanks, Emily. Always a pleasure. She's an amazing, remarkable person. Thank you for spearheading this efforts for past 5 years. So big hand to Emily. Thanks so much for having me here. So I work for the department, and I have no disclosures today. So I want to confess something. I have a love affair with water. I grew up in a coastal town. I learned how to swim as an adult. And I actually told my kids that I'm moving to New York because I want to enjoy the pristine beaches that New York has to offer. And that's not, it's a reality. I actually lived in a place close to here. This is the southern tip of Massachusetts. So I used to work in a place called New Bedford, which is right around this area. And then there's Dartmouth, where I used to live. But this particular image breaks my heart. This is a timeline assessment of how our world is changing. We are seeing this significant change from 1984, where there's a sort of intact shores, to destruction of the shores that's happening right in front of our eyes. And being close to a coastal city or living in one, I feel for it. There's a report just came out that New York is sinking as well, especially Manhattan. So there's a lot to digest and think about. My interest has always been working communities. I'm an occupational medicine expert, and I've done that for years. I've been in practice for some time. And so the group that really inspires me is this group, low-income working communities. I wish we can add the working part here. And that's the most vulnerable population that we see, that has a lot of challenges that is hard to come by. I also work with responders. Of course, I'm part of World Trade Center responder group. And so there's a lot of things that we can do to help these communities. And that brings me to a group of people that I really admire, which is outdoor construction workers. They work outside long hours. They have little protection as far as heat is concerned. And they're part of the economy of US. Building more houses, or getting people in homes is one of the most fascinating things, and has run America's economy for a while. So these are heroes or celebrities for me, and anything I can do to help them is very, very important. So I do want to highlight something which actually is fascinating. You're seeing a video of a monster of a storm that hit Houston, Texas, in 2017. This is some of the 911 calls that were made as the hurricane came on the land and then moved to Beaumont area, Port Arthur area. So it's basically circulating. It's the people on the ground describe it as the unrelenting torture. It was rain for 8-9 days. It was unbelievable in terms of the destruction that came together for Hurricane Harvey. And that kind of put me to a path where this love affair with water become more of a cause. Hurricane Harvey was a force to reckon with. You can see the immense destruction that occurred in Houston at the time. It was unprecedented. Actually, after Katrina, this was one of the most expensive storm or hurricane that people have seen. But Houston is different. Houston is not what Louisiana was. Houston has a lot of chemical industries. It's a hub for petrochemical plants. So there's a lot of things to consider here. It came ashore August 27, 2017, changed at least my life. I was connected to some of the faculties on the ground at the time and really saw the destruction through and through with Hurricane Harvey. So the homes got flooded. There was a significant destruction in terms of property and damage. This is not unusual. You see it in the news all the time as the destruction is occurring. The most important thing that I focused on was, what are we doing for the communities and workers when the hurricane hit? So there was a FEMA trucks, there was a lot of assistance that was sent to Houston at the time. But the interesting thing that really captured my mind was 8, 9, or 10 days after the hurricane has subsided. There was destruction all over the place. You can see some of the images. The homes were destroyed. They were condemned. People threw out stuff, carpets that were completely destroyed. And it was unlivable place, Houston itself. This is my colleague. He works at the University of Texas, Brett Perkison. He decided to help the community. This was before the pandemic, so he had a bunch of N95 masks that he took out and distributed free of charge to the community, because they saw a rise in respiratory infections or respiratory distress in communities that were impacted after the hurricane, which was very profound, and especially people with respiratory-related illness. There was a surge of acuity of condition that they saw post-hurricane. We actually joined hand together and basically started a project which actually took a name called Pocket Arc. Pocket Arc is a fancy name for something that is very, very mundane and basic. It was funded by National Institute of Environmental Health Sciences, this project. What we did was we are trying to help the workers who went in 8-9 days after the hurricane and tried to rebuild the community. But the unfortunate part is these workers has no safety trainings. They weren't sure what to wear, how to use PPE, what harnesses they need to climb up the roof. So the program Pocket Arc does, it provides micro learning to these individuals that are going in to do construction in flood zone areas. We actually give them opportunity to learn about N95, gloves, what need to wear, what are the health effects that they will probably see when they go into a flood zone. And one of the most interesting thing is these guys get picked up from one place and being dropped off to another place, which is miles away with no transportation. And guess what? This is post-hurricane environment, so there's no transportation available. So they walked for miles after they were deployed and worked in the construction zone. So we tried to design something that is very simple for them to identify, figuring out where they are, sending that message to the person who can pick them up. And we also worked on training and action plan for those individuals who are working. So it comes together over a course of years. We build this program that helps the worker train on and become ready to be deployed. It is a self-guiding training. It provides resources. It provides online information to these individuals who've been neglected post-hurricane. And then we also are trying to build a system that these individuals can be managed from different parts of the country. For example, there's a group called Resilient Force. If you have never seen a documentary on Netflix, there's one available. These are workers who go into flood zones after hurricane and do reconstruction work. And it's a fascinating story of what they have and what kind of resources they have available at the time. So we are trying to empower the group, the Resilient Force, which is a nonprofit organization, an advocacy organization, to help these workers find the resources they need and to get deployed in the areas that they can work in. So this is the second part of the program that we're working on building it. The project is basically now funded for phase 2, and so we're continuing to see the progress that we're making. All this is past 5 years when the pandemic came through and we became part of the COVID-19 pandemic that emerged in New York City, and we became the epicenter of the epicenter in the US. And so that I started to think about things that we saw with Hurricane Harvey. And as I mentioned, that post-hurricane, we saw an increase in respiratory illness in the communities. And that made me think that I can do something right here in New York City. So this is a recently funded P30 project that it just came about. CUNY and NYU and the city of New York are starting to put this interesting sensors called flood nets across the communities. There are about 100 plus sensors. The idea is to put about 500 sensors. They're ultrasonic sensors that actually measures the water in the path. And they basically record in real time. So every 5 seconds, the recording gets done. And then they display how much water is in one community. So we can see floodwaters here. We can see floodwaters in the Queens area or Staten Island area. And this is real-time information. FloodNet is unique to New York City. At least I have not seen it anywhere around the world or in other cities. And what it's doing, it's actually informing us about something that we don't have a good understanding. We're talking about not only hurricanes, but the flooding that occurs on a daily basis in these communities. Increasing surf, the gravitational pull, basically the oceanographic changes that occurs, or the temperature elevation can cause flooding. These are things that FloodNet is picking up, which is incredible. So I have an interesting vantage point here. I can actually see flood information at a microscopic level and can relate it to the respiratory condition in a community. Incredible, right? So I can identify, and that's the goal, that's the aim of the study, is to identify if we can see that micro flooding, which is small amount of flooding, not at a level of hurricane, can really increase respiratory infections in a community. And that is profound. That is creating a link between climate change and a really important health outcome is preventing respiratory infections like COVID or flu and others. And there's evidence to support that. There's evidence that there is a relative risk increases with hurricanes. And we have seen it with Hurricane Harvey. Katrina has a similar kind of example. So working with CUNY, City University of New York, and NYU and other folks, I think we can establish that link in a better way. And that's where I think the focus need to be. How can we design studies, research studies, that can see this link between the climate change and health in a very objective way, so we can define some interventions in the communities of scale and that impact the community in general. I'm just going to finish off with one small plug in terms of this work is national, global. I can't do it on my own. I need to collaborate and work with different people. So that is an idea behind a podcast, which is called MOccH, and we do a lot of conversations on climate, and they're called climate conversations. So if you have a phone, Apple or Android, regardless, you can just type in OCC Pod in your podcast app, which is freely available with all operating systems, and you can download and listen to it. It's some of the fascinating conversations I had across the nation with some of the leading experts in wildfires or hurricanes or disasters. And particularly recently, the conversation was about respiratory diseases in a military or active personnel or veterans, which is the last episode we just published. So there's a lot to be done. So I encourage you to think, take a moment and join us. Thanks.
Can you push the button right? There you go.
Next, Dr. Lasarius.
Thank you very much, Emily, and good morning, everybody. Good afternoon, good evening to those who are watching us online. Thank you very much for coming. My name is Jasminka Goldoni-Lestadius. I'm Senior Occupational Medicine Specialist in the World Bank among my other colleagues in Health and Safety Directorate. The World Bank Group is a big global international organization, and it has headquarters in Washington, D.C., and has about 200 offices in more than 150 countries across the world. So we can safely say that we are practicing global occupational and environmental medicine. Climate change is very high on Bank's agenda. So in fiscal year 2022, we invested more than $31 billion in various projects related to climate change, and plan to actually double this sum in the upcoming years. If you're interested in all details about the current ongoing projects and results of them, I advise you to look into World Bank Group Climate Change Action Plan 2021 to 2025 and Global GRI Index Report 2022 for all the details. These documents are available online for everyone to read. They are very comprehensive, many chapters. They will not be a topic of our conversation today. I was thinking for today's talking points to rather that you would be maybe more interested to peek into the bank to see what the bank does inside of its walls, on its premises and for its workforce. So we have a corporate responsibility program, which is actually responsibility for all of us, from senior management to every staff member. But a big role in that program is played by so-called facilities or global corporate solutions. So they are playing a major actually role by their commitment to 10 sustainability principles. I will go briefly through them at the end. These principles are focused on several major topics in the bank, and this is corporate real estate, travel, food, commuting, waste and recycling, and other initiatives, mostly printing, reducing third-class mail, like 30 tons of this mail was reduced last year. So all of them are very important, could be topic of the whole workshop there. But I thought that maybe waste and recycling is a very good example of what it really looks like and something that could be easily applied in other organizations. So how it looked like in practice. One day we came to offices and there were no waste bins, no trash bins, not in my office. I went to my colleague, they didn't have either. There was none in a meeting room, but there were these kind of recycling stations in all common spaces and corridors. So what we had to do is actually to take care of all our waste and bring these peels of bananas and coffee mug to this sorting station. And this became our practice that led to the fact that 85% of waste is in the bank is recycled or composted. So it was a very good program. Of course, mandatory. Nobody could not commit to it, but it was really successful and very much appreciated. It is important with such program to get buy-in from staff, to get their trust that things really work. So you have to measure the impact of what you're doing. What happened with our trash bins? Well, they were turned into scholarship. So 15,000 of waste bins were turned into scholarship for students in need of financial support. So it was kind of really, not to mention reduction of staff that was cleaning, emptying 15,000 bins every day. All of a sudden, the trash was all sorted and centralized. We also have the greening room, which is very useful when you don't need some office material, you leave it there. Also, when you need something, you check whether there are new binders or pens or whatever. So you are not ordering every time everything you need. Recycling room, very well used for batteries, for light bulbs. We have campaigns to collect unused electronics, expired medicals, and so on. So that was about a little bit about our premises and the material stuff. So what about our workforce? We have about 10,000 staff at headquarters in Washington, D.C., 10,000 all across the world in 140 plus countries. And we take care also about their dependents, about consultants, about also we have programs from retirees. So we have huge global population to take care of. And when it comes to climate change, it is actually a part of our integrated health and safety risk management. So this is a 3-tier model where we assess and mitigate risk in general environment. Let me see whether this works. Okay, doesn't know how to. Okay, in general environment, in work environment, at the level also of individual and population. And to see how it works in practice, I will give you an example of air pollution. So at the tier 3 level, in general environment, we are monitoring all kinds of data resources related to air pollution. globally. So WHO resources, but we also have monitoring air pollution index scale on a daily basis. You see on the world of the map how these critical points are marked. You can see also that the levels of 301 to 500 index values are considered hazardous and they're considered as emergency condition. And then next to it, you see the measure in New Delhi, 999. It's off charts. Maybe it's even higher, but it doesn't measure further. So we have a lot of such places globally with extremely high air pollution and thousands of staff that live there and travelers who travel there. So clearly, based on this monitoring of general environment, we can prioritize our action to most dangerous places. And at the moment, it changes from time to time. So we have to monitor all the time. Second tier is at the work environment. So this is where we can act actually to help our population to be not to be exposed to so high level of air pollution. So we are implementing hierarchy of controls. Those of you who are occupational, present or future occupational and environmental medicine physicians, you know, you're familiar with hierarchy of controls. The best is, of course, to work on elimination and substitution of any hazard. Here, it is not available to us as occupational medicine physician, but at this level, of course, banks all kinds of projects that reduce overall air pollution by interventions in traffic or fuel consumption and so on. They are acting on this level. However, we are implementing engineered controls, administrative controls, and when it's really necessary, personal protective equipment. It should be the smallest portion of this kind of intervention. So this is what we do not only at workplaces where our people are every day for hours, but also we do implement such methods for cars, which they use for commuting, and then at homes as well, as much as we can, especially during the pandemic. Home offices were main offices, so we had to transfer our focus from work environment also to home environment. And finally, personal and population health risks to illustrate on personal level. So before assigning staff to places with so high pollution, at least occasionally appearing or continuously, we clear them medically. We are careful not to send people with asthma, with chronic respiratory or cardiovascular diseases to such assignment. Problem is that we cannot quite enforce this kind of advisory. So sometimes people do go, and this, of course, results in their lower productivity than usual. They use a lot of sick leave, and we had also a situation when we had to medically evacuate staff because they couldn't stay longer in such environment, and they didn't have adequate health services there. On population health risk, this is one example result of our health and safety risk assessment. We have regular surveys where we explore all kinds of health risk and safety risk in our population. So particularly for India or New Delhi office, we realized that they have more smokers than many other mother population in other locations. So it, of course, gave us evidence-based reason to introduce smoking cessation programs there, because in addition to inhaling this actually toxic soup, to add smoking, this is really something that is at least preventable from our perspective. These are 10 sustainability principles we are committed to ensure resource efficiency, reduce waste, eliminate corruption, be climate resilient, energy smart, water efficient, enhance diversity and inclusion, ensure staff well-being, promote sustainable land management, and engage and preserve the community where we act and live. So there is this is a very detailed slide. There are all resources and references based on which we propose action, and then we have also indicators to measure success. The picture is of the green roof in IFC building in Washington, DC, where we are growing vegetables. It's kind of a live video how you look into which vegetable is where and what it means and so on. But it is on the firewall in the bank, so I cannot show you that. And then, for example, also we don't have plastic bottles in the bank at all. We have some sort of different type of containers that are environmental friendly. There are a lot of things you can do. I mean, research is very important, policies are very important, but when it comes to doing it, then you feel you meet the problem there, because you can say to people, oh, well, don't use your car, take your bike for work. Yeah, some do, but most of people stay with the car. So all these programs, compliance is a problem. If they're mandatory, like decentralized trash collection, or we have centralized printing, where we got rid all the printers in all offices, again, thousands of them, and have centralized printer. This is mandatory, so people have to participate. But in voluntary program, you have to have very good communication campaign, explain why they're doing, and have trust of staff to follow you on that. And so this would be all. Thank you very much. This is my contact information if you're interested. Thank you.
So much. Okay, thank you so much, Jasminka. Okay, great. Okay, so we just had some presentations looking at 3 different perspectives of workforce. Dr. Nabil talking about prevention in real time in climate change scenarios. Dr. Goldoni Lestadi is talking about how organizations, large organizations, usually corporate organizations, are managing climate change, both reducing their own contribution to climate change, but then again, protecting the workforce. And of course, Dr. Sokas talking about some of the direct impacts of climate change on the worker. And I want to go back to Dr. Sokas. Remember, we can have questions from her. To begin the question and answer period, and a question came in online for you, Rosie. It's given that the CDC found 40% of school-age children have existing chronic illnesses, and given lack of good ventilation air movement in schools, at what set point should classroom schools be closed? 32 degrees Celsius or lower.
Well, so it's interesting. I mean, again, I'm going to pull a John Howard here and say, you know, I don't have the answer to this, but what's interesting is when you look at the optimal temperature for getting work done, it's actually lower for some of the intellectual jobs. I mean, so there's environmental characteristics that have to be in place for people to be able to sit and think and do intellectual work that's as well studied as the need to make sure that somebody's not running around a playground, you know, in the sunlight and all of that. So, so the real question is, how can you maximize what the kids are going to be learning and at what stage? So they have to have, I mean, all right. So they need to have air conditioning. I mean, they need to have, we're going to have to get air conditioning for a variety of reasons.
Is heat itself an inhibitor of?
Heat itself is an inhibitor of people being able to pay attention.
Okay.
So it's going to inhibit their learning process. You're not going to be as productive in a sedentary position with heat. So it is also an issue. There are so many reasons they have to get air conditioning. I mean, they have to get air conditioning for the ventilation changes that are recommended for infectious diseases. It's not just COVID, it's influenza. It's all the things that Ishmael was just talking about in terms of, you know, if you have increased flooding or mold in the room. So improved ventilation is probably like 1, 2, and 3 on the school's list. And stopping school, I mean, just closing it and having kids go home is the last thing you really want to do, obviously. I mean, we saw that. So I don't have the answer. I don't have the answer at what temperature schools should close and kids should go home. But schools need to prioritize HVAC systems, which includes the air conditioning as well as all the other stuff we're talking about for COVID. And then outdoor play spaces, obviously there needs to be shade in those. There needs to be, there's a whole lot of safety issues that go along with that. It's a challenge we do much more poorly with our public education than in many other countries. And the idea that we can't afford it is just not acceptable.
Another question that I'm going to ask each of you to weigh in from your different perspectives is the increase in workplace violence. By the way, healthcare facilities, as we know, are the #1 area where workplace violence occurs. Goes up with a rising temperature. So if each of you, perhaps from an organizational standpoint, Jasmine, if you have thought about this at the World Bank, and what should some of these approaches be to get a handle on violence in the workplace as the temperature goes up?
To be honest, we didn't notice that connection. So it can also come to the fact that we didn't collect data in such a way. And honest about workplace violence, we don't have much information. We have information about domestic violence, for example. That's a very clearly a problem, and we have a program to prevent it. But workplace violence, it doesn't come often to us. It doesn't mean that it doesn't exist. It doesn't mean it's not connected with climate change or higher temperature, but not aware of it.
No, it's not. You're not actively
coming
doing
up.
surveillance.
Yes, we didn't have workers' comp cases. We didn't have injuries. We didn't have complaints. Maybe it's hidden somewhere in shadows, but then we have to ask directly the question in the survey, which will make our survey even bigger. So anyway, there's something to think about. Thank you.
Go ahead.
I'm working with the institution, particularly hospitals. The biggest concern that we always get is workplace violence where a patient is disoriented or not really complying with the directions. And that's where tragic incidents happens. There's some contribution, of course, with the excessive heat. You can have disorientation. If you're on antipsychotic medications, that can potentially cause increased temperatures as well, and that can produce delirium or other mental health changes. And that can indirectly contribute to increase in violence, basically. So there's a lot of different connections, unfortunately, that we need to establish. But there's no direct link. I always think about the causality and this is how it goes, but that's not always the case in climate change and health perspective. So start thinking broadly in terms of particularly epidemiologists in the group. How can we answer the question?
Before I move on from individual patients with Rosemary, a couple questions. What are the work rest cycles for outdoor workers?
So NIEHS has a nice setup where it says if the temperature and humidity is this high, then you're supposed to be working 45 minutes work and then 15 minutes rest. And they keep going up. So if it's higher and more humid, it's 30 and 30. And when the disaster, the Gulf oil spill occurred, the Deepwater Horizon oil spill occurred, what happened was the federal government hired a bunch of local community members to do the cleanup. So they were doing the shore cleanup. They were people who were not, medically cleared or physically fit. And so they were really pretty aggressive about implementing and got to the point fairly quickly of saying, okay, they're cleaning up these wads of oil and stuff on the beach. Walking on the beach itself is a little bit challenging in order to do that. And they wound up with 15 minutes of work to 45 minutes of rest. And then, of course, the local newspapers get a hold of it and say, oh, this is your tax dollars not at work, and there's a lot of, back and forth there. But the interesting thing is that there's actually some physiologic studies that show that even young, healthy people following, they put them on a treadmill and they follow the 45 minutes work, 15 minutes rest. They show that while they still have the same, oxygen uptake, capability, so they're technically able to do the same work, that their heart rate and their stroke volume changes actually kind of accumulate over a couple of hours. So even what NIEHS is telling us, which is way far from what any of the regulators are putting into place. I mean, they're just not even touching that. We may be accumulating a little bit of stress over the course of an 8-hour day. So it just speaks to the need for more frequent rest breaks, basically.
Is there an absolute temperature under which people
Nobody
not
should be
doing
working? Yeah, really.
Yeah.
I mean, I think that's what that gets to. And in this country, we don't actually recognize that. So, you have a terrible heat wave out west or someplace, and there'll still be farm workers in the fields, or you'll have a wildfire smoke right next to them. And the wildfire firefighters are, some of the people who are also extremely exposed. Those people, when you can measure decrements in urinary, in renal function over the course of an 8-hour shift. I mean, we don't see what you see in Central America and Sri Lanka in terms of lots of young people with no kidneys as much. Well, we don't see that here because we don't have this desperate amount of working that people are doing, in some of these areas with this incredibly high heat. But we haven't had that kind of high heat before, right? So we don't know what we're going to be seeing. And again, I'm going to duck this, but I mean, 120 degrees, you're not supposed to be out there. I don't know the exact number for calling a halt, but for example, in the Middle East, in many of the Gulf countries, you're not allowed to have people working outdoors between noon and 3, for example, that kind of stuff. And even that's not really that great because 4 o'clock, it could be terrible. So what the military does is they'll change things to the early morning or late night, or you train in the middle of the night even. So that's a huge shift that we have to think about. And
did you want to say something about that, Jasmine?
No, I confirm, but it's.
So the IRA includes funding for, it doesn't really quite, it's not really working. Funding for the proliferation of a number of renewable energy industries, primarily in the Southwest. Knowing what given what we're going to see with the expansion of solar in some of these states, this is looking at the future. And as we transition, what are all your thoughts? Anybody jump in if you want to start? Rosie, go ahead.
Sure. So there in California in particular, they've had really, kind of an emphasis on these solar farms. Interestingly, they're of the 20 biggest solar farms in the world. Most are in China or India. Only one is in the United States, and these can have like millions of solar panels out there. So there's some areas in the Middle East where they've actually started experimenting with robots to clean them off, because so there's a lot of worker involvement in setting up and constructing and maintaining and all of the stuff with these solar farms. That's heat right there. I mean, so you're talking your classic heat stroke. And then with all the other technologies, just a couple of little mentions, mining for all of the different components that have to go into the batteries and stuff. So mining is a huge increased need that has lots of occupational safety and health implications. And then the wind towers, when Dr. Howard was talking about those, I mean, when we were at OSHA, we were trying to figure out how you would get inspectors up there. And it's interesting because you can't be big and tough and have a huge shoulder thing because you can't fit up in the top there. So you have to be, and if you're up there and God forbid you have a heart attack, there's really almost no way for people to get you down. I mean, you had to rappel down the side. You had to be that fit. So there's a lot of fitness implications for people who are supposed to be working up top there. And that's, I honestly don't know how well that's being implemented, but that's an issue.
Okay, thank you. A couple questions for Dr. Nabil. Can you talk about how Project ARC came to be, and how do you think this can be utilized during other types of natural disasters for training purposes?
You speak my mind, of course. Thanks for the question. So Pocket ARC organically sort of came out with the fact that we were seeing this desperate workers going into these flood zones and have nothing in front of them. So they were lacking supplies. They didn't have PPEs. They didn't have the training. They're showing up to work because they are desperate to earn some money. And these are southern states. So we're talking about Texas, Louisiana, Florida area, where there's a huge amount of migrant population that's coming into view, and they want to work. So in order to help them at least get the basic training for health and safety, PocketArc became a logical solutions. The problem that we end up understanding after we met with the people, we worked with them, we realized that there is not only a huge need, but the diversity of this population is very significant, both in terms of language, in terms of learning. Most of them cannot speak English at all. Most of them have no high school education whatsoever. They have no idea how to differentiate things. What is a safety harness or a hard hat or helmets? So the interesting part that we did was we started to build the product that can cater to the needs of these special communities. And having done that, or trying to do that, I think PocketArc is well established to take care of all workers who are not at that level, but at a higher level. We can actually help them get basic trainings. We call it micro learning environments. You can do it before deployments and then can be deployed in the field, but you have minimal understanding of safety issues at workplace. You can also define the job for them. We can actually tell them what the hazards are at the workplace while they're being deployed. So definitely it could be used for firefighting job, could be used in hurricane settings, could be used in wildfires or other disasters.
What about mosquito breeding? Could you use some of the technology to detect mosquito breeding so you would know where to treat?
Right, so the ARC has been developed in a geospatial sort of way, and what we're seeing is these individuals getting deployed in certain areas. So if we see a high increase in mosquito population, which could be those different parts of information we can inject into the PocketArc and can inform the worker about the risk that he or she is facing while working.
Thank you. For Jasminka, who is responsible at an organization like World Bank for pulling together all these climate-related programs and evaluations that you guys undertake each year, and then sharing what you're doing, disclosing that with everyone? Now, you are a non-governmental organization, correct?
Yes.
So there's no requirement that you do all this stuff.
No.
Okay, talk about that if you
We
will.
are international organization, so we don't have to actually follow national standards. We are creating our own inside the organization.
Why?
Why? Because otherwise we are present in 140 countries, so there is no way that we comply with the standards that are all different. So we have to have our own standard, which we try to achieve some sort of at least minimal standard that is the same in everywhere, in all locations. We have locations in very remote parts of the world, so we cannot have the same criteria for work environment there. And so that's one thing. What was the rest of it?
So the question is really about
Who is
organizing in
responsible?
three
Yes.
tranches. You look at the
Yeah.
environmental, you
Yes.
look at the social, which is your workforce and the communities in which
Yeah.
you reside, and then you must have governance principles that
have,
dictate how
yeah.
you go about doing that.
We do have, first of all, policies that are kind of basis for whatever we are doing, and then committees that have all stakeholders in the organization taking decisions, because all these factors are actually you need multiple perspectives and professions involved. So in such committees, we have everybody from facilities from health services, legal, security people, HR people. So there are representatives of all the stakeholders that are making decisions together and make sure that they are compliant with the policies that are created in the organization. And then for many programs, we have also focal points or champions. So people who volunteer to make sure that some programs are implemented in various locations in the same way. So there's a whole network, and this is basically how we function in all implementation of integrated health and safety.
So it's not a
management
separate
system.
thing. It's
It is
fully
not
integrated
it is
into
fully
the business.
integrated, and it's not anyone's personal responsibility. You cannot alone fight anything. So in such complex, big organization, you have these committees and multiple stakeholders, so that responsibility is actually on everybody's shoulders.
And climate is a specific.
Climate is part of our integrated health and
Right.
safety management system, but there is a specific corporate responsibility part that plans all these kind of programs in areas that I listed. That are very, I mean, in the World Bank talking about main occupational health hazards and risks for all population, ergonomics is on the top, because we know from the survey that our staff works in pain, and especially during home-based work with improvised stations and whatever he tried to do. I thought that it will be a few months. So ergonomics is a big one for everybody and for travelers. And there are 70% of staff are travelers to low and middle income countries. We have 1 million travel days per year before the pandemic. For them, road safety is the main risk. So we focus on that one, which includes indirect effect on climate as well, but mostly on the safety side.
Terrific. We have a question from somebody in the audience from Texas Tech. Did somebody traveled here? Dr. Jaya Maran. Jaya Maran, are they here? Oh, we're going to have a live question. So terrific. Thank you.
Hi, I'm a second-year medical student, and so a lot of literature has kind of shown, and this question is for mostly targeted at Dr. Sokas, and a lot of literature, like you kind of pointed out, related to redlining is communities of color have been limited in their access to green space, and green space is particularly important, not only for physical and mental health outcomes, but also in climate resilience with regards to, we've seen even in Hurricane Harvey, in the post communities that had access to more green space had better mental health outcomes. And it also can help prevent erosion itself. But sometimes what we've been seeing often is to help mitigate that, we install a green space right in these communities, and then the property value rises, and then those who are intended to benefit from it are driven out. How can we equitably / sustainably increase green space access?
That's a great question. There's a nice paper, and I can't remember the author's names, out of Philadelphia. So in Philadelphia, what they did was they did this really intensive study where they had 400 empty lots. They took the empty lots and half of them they improved, but they improved them with community input because they were also, it was a qualitative study. They had focus groups as well as they had data. They could show that when they cleaned up a vacant lot and made it, to a certain level. Now it's not talking about, making these lovely, kind of long roadways and stuff like that. But at a fairly small level, they were able to demonstrate, it wasn't a climate study. They were looking at crime. So it was perceptions of crime and actual crime statistics from the police. They found significant decreases, and the differences were more marked in areas of lower SES neighborhoods compared to other neighborhoods. So there was a lot of discussion back and forth about not doing gentrification, not having it be so beautiful that people are going to want to come in and displace the people who are already there and raise the taxes and all of that. But you had lots of these, in Philly, it's all spread out. So there were a number of these, and the quantity of them allowed people to stay out a little bit more, do a little bit more. I mean, it was incremental change. It wasn't kind of huge change. And again, they didn't measure, the canopy and the temperature. The other thing totally separate from what you're asking about. The temperature issue is cooling areas. And there's a national heating subsidy, and some areas have actually allowed it to be used for cooling subsidy for frail elderly and people who are eligible for these kinds of energy subsidies. So there's lots of other programs besides green space, but the green space has to, you're absolutely right. You have to do it in a way that does not, that the community is engaged with it, and that you reduce the risk of gentrification as much as possible.
Okay, quick question for Dr. Nabil. Pocket Arc is a good example of the integration of technology into asynchronously, if you will, reaching out to these populations for a variety of reasons. It might not only be applicable to flooded zones. I know this is your area, so if you can just tell us as we conclude here, what are some of the things we're going to need to be looking at as we integrate more technology as the climate crisis continues forward?
Oh, thanks, Emily. This is a very loaded question as well. When we start working with this population, this specific group, my idea of this group is they're not tech savvy or they don't use the phone or other things. I was pleasantly surprised. So most of these groups, even though they are struggling in terms of financial support, they are very, very much connected with the group itself. And they have mostly Android-based phones that they use on a regular basis. They don't know all the functionality of the phone. They usually have peer leaders who can help them understand some of the functions. But an interesting thing that emerged from our work is they use heavily a thing called WhatsApp, which is a communication channel that they use on a most frequent basis. And that give us a pause in terms of how we can design technology or technology solutions that you're talking about, specifically for this kind of population. We are heavily relying on kind of ways to inform them through illustrations, images, really sort of connecting with the cultural side of the population so they understand. Soccer is pretty big in central states, Central America and other places. So soccer could be a way to communicate health messages or safety messages to this population. You have an amazing way to connect with different types of population, especially with technology. The question is what your imagination can take you and how you can inform these individuals about the basic safety needs. And there's huge safety needs, and I don't want to minimize that. Most of them really understand how to pick up the harness and use it. They've never done that before. Most people come to work with slippers on. They don't have hard hats or boots because they were never given the choice or never have the money to buy that. So things we can do with technologies in a simplistic fashion, but very importantly, is that we need to understand what our study population is and how we can help them.
Okay. All right. I think we are out of time. We're at noon, and I'll let Terry take it from there.
Thank you. Thank you. Very exciting panel. I'd like to now introduce Dr. Albert Rizzo. Dr. Rizzo is the Chief Medical Officer for the American Lung Association and board certified internal medicine, pulmonary, critical care, and sleep medicine. We are honored that every year he has given us an update on the American Lung Association's annual State of the Air report, which analyzes air quality across the country. Dr. Rizzo.
Hello and thank you. And I believe somebody has to stop sharing their screen so I can share mine. It won't let me. Let's try again. Here we go. Great. So again, thank you for having me again this year. I was really enjoying the lectures this morning, and I wish I could be there in person with you. But this is a great opportunity for us to share our yearly report that shows trends over the year of mainly two pollutants, ozone and particle matter. And we know these are the most important ones that affect human health. I know I stand between you and lunch, so I'm going to try to get through this in a timely manner. I have no financial disclosures. And I wanted to say that during the presentation, we'll talk about the findings from the annual report. And then near the end, I'll also talk about some opportunities to help you and others advocate for healthy air, much along the lines of Sara Zaat's request earlier today. So we began this report back in 2000, and it uses a methodology that starts out with reliable, quality assured data from the EPA monitors. And it uses an unbiased grading system to provide credible and hopefully easy to understand in lay terms information to the public about the air we breathe. The data in this year report always includes 3 previous years. So this report includes 2019, 2020, and 2021. And the lag is to allow for the validation and verification of the issues that I mentioned. So the State of the Air report focuses, as I said, mainly on ozone and particle pollution. And EPA monitors are used throughout the country. The outside agency we use to characterize average ozone concentration information, as well as the daily particle pollution and annual particle pollution spikes. That's an outside agency verifies that for us. Some of the key messages are on this slide. It doesn't report every pollutant, but as I said, mainly ozone and particle matter. It's also important that the information is given in lay terms of these 922 counties across the country. And you must remember, we're not covering the entire country. There are more monitors out there than what there are more counties out there than what we can measure. We do rank the 25 metro areas with the worst pollution, as well as the cleanest for the 3 categories: ozone, daily particle pollution, and annual particle pollution. And those grades are A through F for the counties. We also give the federal government a grade as well. Okay, there we go. The report's important as an advocacy tool for the American Lung Association. The 3 arms of our mission include health promotion, research, and advocacy. And advocacy is key with regard to some of the climate changes and environmental issues that we have to deal with. We understand that the unhealthy air impacts districts, and policymakers need to understand this when they are asked to legislate for their the legislative bodies that they represent. Quickly, let's go over again. This is the particle pollution. We mainly measure 2.5. However, 2.5 carries with it even smaller particles of the 0.15 microns. We know that 2.5 and smaller are the ones that are able to be respirated down into the lower parts of the lung and can cause airway inflammation and many of the respiratory effects that we see. And we know the smaller particles, the 0.1 micron, are small enough to go across the alveolar capillary membrane, get into the circulatory system, and probably represent the main way that we see non-respiratory health effects of pollution. I also mentioned ozone, the other main factor. The exposure to unhealthy levels of ozone really make it hard to breathe, even for those who don't have an underlying lung problem. In 2019, 2020, and 2021, there were 103 million people who lived in the 124 counties that earned an F for ozone. That means that more than 30% of the nation's population, including 23.6 million children, 15.4 million people of age 65 or older, and millions in other groups at high risk of health, are exposed to high levels of ozone enough days to earn the air they breathe a failing grade. Although ozone pollution remains a serious threat to the public, this year's report does show a trend in a positive direction. The number of people living in counties with failing grades for ozone actually declined by more than 19 million this year. Now on this slide, you see the list of well-known and scientifically documented symptoms and diseases affected by poor air quality. Decades of peer-reviewed literature highlights that there are major respiratory and non-respiratory risks associated with these pollutants. We continue to bring these to the attention and challenges of the EPA and other legislative bodies. So again, some of the key messages: 120 million people live in unhealthy levels of air pollution. 17.6 million people fewer than last year, a sign of continuing progress, as I mentioned earlier. But we will see, and I'll go into this a little bit deeper, that there's growing disparities, meaning that the progress we're making is not equally shared. Ozone may have had a trend downward, but as you'll see, deadly particle pollution continues to rise. And the major differences in exposure to unhealthy levels of air exist between eastern and western states and between people of color and of white. As this slide shows, more than 1 in 3 individuals live in places with unhealthy levels of pollution. The proportion of the population in those counties varies by the pollutant, and the majority of US counties actually don't have monitors, as I mentioned. It means that the communities, especially rural ones, don't have any official monitored information on the air quality. It's important to note that that population numbers include sections of and places where air pollution data does not reflect the entire population of those groups in the United States. As you can see on this slide, we know that there are burdens of poor air quality that don't fall equally. There are major disparities in terms of who's breathing the worst air pollution. In this year's report, we saw that nationally, people of color were 61% more likely to live in a county with a failing grade, and 3.7 times more likely to live in a county with at least 3 failing grades in ozone particle pollution on a daily basis as well as on a yearly basis. Now, these are county level views, and there are certainly more refined data sets that exist highlighting more local disparities. An example of that is the US EPA agency released a report in March of last year showing that there are 72 million Americans living in close proximity to major trucking routes, and they tend to be lower income and people of color. This was touched on a little bit earlier. The EPA defines environmental justice as the fair treatment and meaningful involvement of all people regardless of race, color, national origin, or income with respect to developing, implementing, and enforcing environmental laws, regulations, and policies. None of us want to live next door to an incinerator, an oil refinery, a port, a toxic waste dump, or other polluting site. Yet millions around the world do so, putting them at higher risk for health effects. In a bit, I'll discuss some of the state literature, state data. It gives a better overview of the disparities issue. This slide, however, shows a study pointing out the unequal aspects of contribution to air pollution versus those who are exposed to air pollution. This was also touched on earlier that historically racist zoning policies and the discriminatory lending practices known as redlining combined to keep polluting industries and car-choked highways away from white neighborhoods and have turned communities of color, especially poor and working class communities of color, into sacrifice zones where residents are forced to breathe dirty air and suffer the many health problems associated with it. Now, when the EPA is considering stronger standards of air quality, the opposing forces at EPA hearings are also concerned about the cost of implementing cleaner standards and its effect on the economy in general. But when thinking about this, it's important to keep in mind that despite pollutants' claims of being the victims of the Clean Air Act, the reality for the country is different. This graph developed by the EPA over years shows that we can have clean air and a good economy. The graph tells us the story of improving efficiency and emission control, that we're able to have cleaner air and less emissions without hurting our economy. So the Clean Air Act is working. Clean Air Act of 1970 has saved millions of lives and trillions of dollars. Pollution controls on industry and power plants and the retirement of old dirty fleets have significantly reduced emissions of particle and ozone precursors. However, there is real concern that climate change-driven wildfires and droughts are outpacing progress and also resulting in growing disparity between air quality in the eastern and western states. Here's more data pointing out the rise in particle pollution, with more people living in areas with dangerous spikes compared to earlier reports, and cities hitting some of their worst particle pollution levels recorded. 64 million living in counties with F grades for daily pollution, and 18 million living in counties with failing grades for year-round particle pollution. Now, we report the top 25, the worst on this list, the top 10 right now. Pittsburgh and Lancaster are the only eastern cities in the top 25. So mostly this occurs in the western states. And this is for the short-term particle pollution. Particle pollution seems to be more distributed across the country. The worst 25 states were more distributed, and although cities more affected by Western drought and wildfires still represent the largest share, Eastern and Midwestern cities with high power plant emissions, as well as local industrial and mobile sources of year-round particle pollution, continue to rise up on the list. In addition to Indianapolis, the number 10 spot, other cities east of the Mississippi include Detroit, Pittsburgh, Augusta, Georgia, and Cincinnati. Mentioned earlier, ozone is some good news. Fewer counties got Fs for ozone than ever in the history of our State of the Air report. And 6 eastern states, Delaware, Georgia, Massachusetts, North Carolina, Rhode Island, and Tennessee had no counties with a failing grade for the first time since we started reporting. The 25 most ozone polluted cities experienced fewer bad air days on average, and 6 of the 25 worst cities for ozone saw their lowest levels ever. So there is some hope in this. And here are the most polluted cities by ozone. New York and the Newark area ranked in the top 25, but as you see, much of the other cities are in the West. Now, this is alphabetical. This is not representing all the clean cities. These are among the cleanest, and there are some that do not have county monitors. So just take that with a grain of salt. Now, what about COVID? Hasn't been talked about too much today, but this report included 2 years of data from the COVID years. The change in the activity patterns may have caused the ozone levels that we saw. In other words, the lockdowns may have contributed to improved ozone that we saw. Early in the days of COVID-19, there were several well-respected research teams that did identify a possible link between long-term exposure to air pollution and especially the PM 2.5 and increased risk of infection and death from SARS-CoV-2. However, there were some methodological issues that came up out of those reports, so we remain a little uncertain as to whether or not COVID-19 played a significant role in increasing effects of air pollution. But we know air pollution in general affects the respiratory airways and does increase the incidence of respiratory infections. So stay tuned for specific COVID reports. Now to get to some advocacy opportunities. As clinicians, you can do things as well as recommend things for your patients to do. Certainly getting them in the habit of checking their air quality on a daily basis can help them determine what activities they should be doing that day. And also teaches them some of the things they can be doing on their own to decrease the pollution around them. And as a health professional, we invite you to join lung.org Climate Change is Health and become an active advocate. This is an easy way to obtain newsletters and also take action with your senators and congressmen. And as was talked about earlier by Sara Zaat, we have many of our spokespersons who do end up testifying at state and federal legislatures, and patients' voices are important too. Here in the lower left, it's a mother of an asthmatic testifying with me in Congress. So join the ALA, and we could act as both at the state and federal level, we can help you leverage your voice if you want to become a volunteer. Here are 2 specific issues that we're dealing with right now. Take a scan of this or go to the lung.org, take action, and add your list to the names. For questions, Diana Van Fleet is in our Washington, D.C. office. You can also contact me for information as well. And as the slide says, when you can't breathe, nothing else matters. So hopefully I can get you to lunch, and I'll be glad to take some questions if we have time.
Thank you, Dr. Rizzo.
Dr. Rizzo, can you please stop sharing?
Yep.
Thank you. We do have one question. Experiencing firsthand events like wildfires and floods can be devastating. Changes in air temperature or air quality are more subtle. How do we communicate the importance of the health impacts?
Well, I think it's on multiple levels. Certainly as a voluntary health agency, we use everything we can from our websites to social media alerts, PSAs to educate the public about the importance of air quality and checking on a regular basis. But I think it then falls on physicians, the local physicians, healthcare providers, to make sure they educate the patients, especially those that are already afflicted with a lung disease that are at risk for flare-ups due to a change in air quality. Even a change from the green to yellow or orange air quality index on a daily basis puts those who are sensitive with asthma or COPD at risk of having a flare. So I think it falls on agencies like the Lung Association to educate the population in general, and then physicians to educate their patients specifically.
Okay, another question that came in, is there anything in the report that Sara talked about of the IRA?
No, it doesn't, since this is a 3-year collection which lags, we can't really point to specific legislation that may be impacting that. We could, assume that COVID had some effects on the ozone because of the lockdowns, but we really can't address a specific legislative issue that way.
Okay. Lastly, are there any questions from the audience that you'd like to direct toward Dr. Rizzo? Yes.
Just a minute.
Hi, Dr. Rizzo. Thank
Hello.
you for a great talk. My name is Alex Azan. I had a question regarding the point you just mentioned around how we as clinicians guide our patients and the public generally around sort of how to alter their behavior as it relates to air pollution. I have issue with, I feel like the air quality index is based on the short term, I think, National Ambient Air Quality Standard for PM 2.5. A lot of times that evidence is not really related to sort of what we know in the current literature around sort of levels that are connected to health impacts in the general population, not just people who are more at risk. So as we wait for these sort of these indices to update with more current evidence, how do you recommend sort of, physicians to?
Yeah, I think even though it's good to have people check the air quality index, I think those who are specifically at risk, they always should get in the habit of knowing that during the summer, they should do things earlier in the day because the ozone is going to be worse later in the day. If they know that there had been some type of outdoor event, whether it's wildfires up in Nova Scotia that affect those in Pennsylvania, or wildfires out west that can go hundreds of miles away from the product and affect hundreds of miles away, they need to be aware of those things. And the air quality index by itself may tell them that, but they need to use that guide as a saying, well, this is the day I should close my windows, close the doors, try to minimize what I do outside. If I do go outside, wear a mask that may help me and minimize the amount of time I'm out there. These are individuals who also have to make sure they always have their medications up to date, they have the rescue inhalers on board, and they should be in touch with their physicians on a regular basis because of their chronic condition.
We have another question.
Thank you. Hi, Dr. Rizzo. It's Pune Saberi. I have a question because my air quality index monitor says that today, as well here in Manhattan, as well as in Philadelphia, it's terrible. It's 124, and apparently it's because of all the traveling wildfire, ultrafines and smoke from the Alberta wildfires. Right. And I just want to know if you can speak to that, because it kind of, I want to be perfectly transparent. It kind of adds to my, climate anxiety when, these things happen. I just want to know, like, what can cities do, when these things happen, when there's these events that happen like far from us, where, we've done so much to try to control, what happens like in the city, but this is so outside of our control. And is there anything that can be done, like the way you would filter water, can you, I don't know. What can be done?
Well, I think you talked about a lot of issues that local agencies, the local government needs to have in place to be ready for these types of things. Having enough indoor spaces that are air conditioned and ventilated for individuals who are at risk, or elderly, or those who can't find shelter. I think those have to be available the same way that when there's really cold winters, people open up shelters to bring people homeless in from the cold. So I think that's where advocacy comes into play. We need to be prepared. We hate to put aside monies and supplies and rules for when things might happen. When they do happen, we're not ready. We pay the consequences. So I think that question just begs the issue that we have to be more upfront about advocating for the needs of taking care of the population, not on a regular basis and trying to improve air quality in general, but when these spikes occur due to wildfires or hurricanes, we need to be ready for them. And thank you, Dr. Spree, for the question. She was an interviewee for one of my podcasts on air quality. So nice to hear from you.
Okay, let's give all our speakers and panel discussions and everything a great hand. We will now break for lunch and the poster session. If you are a poster presenter, please head to your poster and give everyone about 30 minutes to check it out. For those online, the link to posters should be in the chat. For those here in person, we please ask our volunteers to point you downstairs to the posters, okay? After viewing the posters, please grab lunch, and I hope you will join me outside in Central Park. Well, I guess not. This is a bad day, huh? Well, so much for that. Okay, but this is a beautiful area, and I guess I could say maybe take your chance or something like that. You know, I don't want to dampen anything. Okay, so lunch is now, and we should be back at 2:15. Okay, 2:15. Okay. Did everyone have a great lunch? Did anybody get out? Oh, great, great. All right. Well, I'd like to welcome you back to the second half of the 5th Annual Climate Change Conference, and we're going to go and get started. The afternoon welcome is going to be given by Dr. Robert Wright. Dr. Wright is the Ethel H. Weiss Professor and Chair of the Department of Environmental Medicine and Public Health, and he's also the co-director of the Institute for Exposomic Research here at the Icahn School of Medicine. Dr. Wright.
Thank you, Terry. So it is my honor to introduce our afternoon keynote speaker, an old friend of mine, Dr. Aubrey K. Miller. He's the Senior Medical Director to the Director of the National Institute of Environmental Health Sciences, where he oversees legislative policy, strategic planning, and coordination of environmental health issues and activities among various U.S. federal agencies. He's also the Deputy Director of the NIH Office of Scientific Coordination, Planning, and Evaluation, and he leads the NIH Disaster Research Response Program, often referred to as DR2, which focuses on improving national and international disaster research capabilities through embracing policies, infrastructure, training, and integration of stakeholders, especially academia and impacted communities such as East Palestine, Ohio, where he's currently working. He's a retired captain of the U.S. Public Health Service Commission Corps. He's board certified in occupational environmental medicine, and it's my honor to introduce him today. Thank you, Dr. Miller.
Thanks, Bob, and it's a pleasure to be back here at Mount Sinai. I always love coming to New York City and seeing good friends here at Mount Sinai. So I'm going to give you a little bit about government, NIH particularly. I've been in many agencies. I started my career at CDC. It was good to see John Howard here this morning. I had spent some time with EPA and the Department of Health and Human Services and a little small stint with FDA. So I kind of know the government agencies and the cultures. I'm going to focus on our NIH efforts and climate change. How many folks here are students? Wow, it's a great turnout. Great to see everybody's here and all your interest in climate change and in public health and applied science and medicine and what we try to do in promoting these programs. So this is kind of what we're seeing and what we're talking about. This is a NOAA slide about billion-dollar disasters. Actually, there's a new version of it out for 2022, but it shows the same trend to what we're seeing. The increasing frequency and severity across the globe of these types of extreme weather events. Now, this does not include healthcare costs. These are just the cost, the $1 trillion in costs, with not even inclusive of healthcare costs. Those aren't tabulated in. So for those that are interested in research and economizing the healthcare costs, they need to be added into this estimation of how much these climate-related extreme weather events are actually costing our nation and where our monies go and how we can actually translate money back to public health outcomes and public health good. So we're in the business of research. Our product is research. NIH is about funding research and trying to promote programs and activities and science that are going to solve fundamental human health issues. More of an edge toward biomedical research. I'm from the National Institute of Environmental Health, where public health is more of our patient versus other institutes like National Cancer Institute, which focuses on a specific disease. So we are focused on trying to translate taxpayer money into research here at just about every hospital and medical research institution across the US, as well as globally, into health impacts. So I won't spend time on these climate impacts. We talked some about that, and Dr. Howard and others covered some of these. This is our new infographic from NIH in the space of climate and health. I kind of think about some of good examples that we can begin to explore. And as NIH, and I'll go a little deeper into our program work now on climate change, how does these health-related changes really beginning to express itself in human physiology, toxicology, and health outcomes? So temperature-related illness, we've talked about examples of kidney disease, hypothermia, wildfire and dust storms, respiratory disease, allergens, rhinitis, hives, eczema, things that you're going to begin to see expressed in population studies. There was a great question before about how do I begin to pick it up? What's the data available? Where are the surveillance systems that I need to be able to understand? And how does the US begin to prioritize our ability to access information and data for outcomes that we're thinking about here? You know, we can apply this to all sorts of health worker outcomes. This is actually a vulnerability assessment by our NIEHS, excuse me, worker training program that they did. They actually started in about 2014 and they re-updated it in 2021, 22. So this is this assessment, and I like it because it kind of gives us a framework for which we can begin to think about these issues. So they broke it down in areas, and I think these are the same areas that John Howard presented this morning: air pollution, biohazards, extreme weather, ambient temperatures, industrial transitions and emerging technologies, ozone depletion. We could think about several others that might fit here, but I like this particular piece of it where they kind of working with grantees and others around the country thinking about, well, what's the framework that we can begin to explore this? So here, if you look across, this is just the biohazards one. You can see on the top line is agriculture. So who's the affected populations in agriculture? We can break that down and begin to look. What kind of natural hazards or new hazards and vulnerabilities are these particular populations experiencing, and how do we track those? What are those occupational health effects that we might be looking for or seeing marks of that are coming out in our studies or coming to the clinic that I'm beginning to see those cases? Are they increased Lyme disease? Is it other types of waterborne illnesses or other things? Work-related factors, individual factors, mostly outdoor. Again, this is really a kind of more of a framework. It doesn't go deep enough, but it's a nice kind of tool to start thinking about not only occupational health, but ways in which we're going to move the ball forward. So it was mentioned earlier, I think it was Sara Zaat mentioned Executive Order 1408. There you are. So that was a kicker for us at NIH. We had to have a program. John Balbus, my colleague and friend, who now leads the Department of Health and Human Services Office of Climate Change and Health Equity, MOccH, we call it. So actually, the Department of Health and Human Services now has an Office of Climate Change and Health Equity, which is wonderful to see. John heads that office up. But also this executive order basically put the agencies on notice, as Sara mentioned. Hey, start doing climate change, start talking about climate change, get back together and start thinking this through about how we can use our resources and our assets to bend the curve, to change the country, to start moving forward. NIH had a climate change working group through many years. It was fairly quiet. It was more quiet during the Trump administration. We're glad to be able to have these conversations again, and having a president with an executive order that actually outlines these issues allows us and the others around the country to be able to engage with government in a more profound and fundamental way. So right now we're led by 7 NIH institutes coming together, which is actually quite unusual. Folks know NIH, typically the 27 institutes work more independently, but we're actually coming together and working. So it's led by NIEHS, National Institute of Environmental Health Sciences, and other institutes are listed here, Fogarty, Minority Health Disparities, et cetera, et cetera. And we have a working group across NIH now with about 140 scientists and staff professionals across all these institutes that are talking about climate change, talking about science, talking about promoting and thinking about these areas. They're either coming from their personal, I care about this, my kids care about this, or professionally, how do I apply my science, my tools, my instruments, my experience to the situation. Here's our fun framework. We call it the cogwheel. So this is our new science, a new climate change and health framework. It's really focusing on this is our goal, is reducing the health threats across the lifespan, building resilience in individuals around the world, especially for those at highest risk. So it has these pillars, these 4 pillars in the center. NIH typical pillar is health effects research. That's what we do intramurally. That's what we fund extramurally. Health equity, a pillar. It's good to see health equity as a pillar, thinking about vulnerable populations. Intervention science as a pillar at NIH. Interesting. That's very translational work. Interventions that are going to change people's lives. Applied public health. Training and capacity building, what we do with you guys, surrounded by that circle of partnerships, and then these cogs of core areas of supporting areas of science that we think are going to be important, along with others areas of science that range from adaptation research. How are we going to adapt to climate change? What does that science look like to adapt to what the world is now changing to? Mitigation's preventing something from happening, mitigation, but that's probably too late for much of what we're doing. We're thinking about how do we understand the health effects of adaptation. There will be mitigation research. Mitigation as we change from one form of energy to another energy. We talked about other types of changing patterns of industry, et cetera. There'll be some opportunities for mitigation. But I think we're too far down for a lot of the mitigation stuff from a health perspective. I think we're starting to work on adaptation, science systems, et cetera, around the cog. So we are, of course, interested in how climate change affects us. How does it affect vulnerable populations, underserved populations with health disparities, exposed workers, persons with disabilities, vulnerability across the life stage, vulnerable those with chronic and comorbidities, populations in low and middle incomes, as was shown before in some of the graphs of how it's not only vulnerable populations in the US, but vulnerable populations across the world that also have lack of access to medical care and are disproportionately being affected by our changing climate. So we've begun to invest. So along with President Biden's executive order, last year, Congress gave NIH some money to start working on climate change a little more deeply and a little more energetically as we begin to move forward. So we started with several things, and I'll tell you about them. So one just got funded. This is a new research coordination center at Boston and Harvard, but this is not just for Boston and Harvard. This is a research coordination center for all of our climate change and health related extramural funding and work. They are supposed to basically serve as a hub to support what we're funding across the country and really across the world. Administrative support, research function, data management function, research capacity building function, to really start to serve as a centering center for all our other activities. Oops, what happened there? Oh, back. Okay, good. So here's another part of the equation as we continue to build. So it started 2021, 22, 23. Now we've added 4 new Alliance for Community Engagement Centers. These centers are focused on community engaged research. Their primary purpose is to work with community organizations to create a centering hub to discuss and advance climate-related health, right? So, so you have University of Alaska working with indigenous populations, looking at food systems, infectious disease, and mental health, and strategies to build adaptive capacity. University of Southern California, University of Colorado, and Public Health Institute in California, all working with different vulnerable populations, looking at different types of health outcomes, one including harmful algal blooms, which we hadn't talked here, and that's the one in Lake County project in California. So looking at different ways and understanding what are communities seeing, how are they being affected, and then how do we, as a community engaged center, then position ourselves to then work with academics. So that is the purpose. They are centralizing the ability for community centers to then begin to work with the academics as we bring the academics into the fold. We also have what's called a NIH Climate and Health Scholars Program that we started last year. These are our 8 current scholars at NIH right now. And we're starting another program. This is, so now these individuals are mostly postdocs and others that have been in the area of climate change and health. They're coming to NIH, they're sharing their expertise, they're sharing their research with the NIH family on campus or working remotely mostly now, like most of us are. But they're placed at these different institutes: Fogarty, National Cancer Institute, National Heart, Lung, and Blood, National Institute of Aging, National Institute of Allergy and Infectious Diseases. Sorry for all the acronyms, but I wouldn't be able to fit it on the slide. Our next call, though, for those that are interested, is in June 2023. So we're going to be putting this out. So there'll be another opportunity, another round for climate scholars to be able to apply and come to NIH or work with NIH to continue to advance. So we're excited that this program's coming to fruition and the scholars are giving lectures and they're doing all sorts of cool stuff. All right, so NIH, we fund. And so this is some of our work right now. We're now funding what's called P20 exploratory grant centers. Who are here at Mount Sinai. You have one of our P30 centers here that Bob's chief of. And, so we're starting to now have climate change exploratory research centers around the country. So we already had one application due date close on May 1st. There's another one on November 6th. But you could see we're building capacity. We're building centers. We're building community centers, pieces of it. These others are notices of special interest. That's NIH telling people you're on notice. Send us your projects, send us your research projects on climate and health. That's new. We hadn't done that up until last 2 years. Same thing on, there's 2 different kinds of notices here. Joined by the National Cancer Institute. How about that? Pretty cool. So National Cancer Institute, innovative research relevant to advancing the understanding of the effects of climate change across the cancer control continuum, from cancer etiology and cancer risks all the way through survivorship and ways to prevent or mitigate health effects. Jumped in with R21 grants and R01 grants now that are open all the way through May of 2026. So this is what we're trying to build, this community of practice. This is where you fall in as students as part of it, as researchers or those interested in this space, is how do we begin to develop a meaningful community of practice, and not just with NIH, but with other partners. We've been talking with the National Science Foundation, Centers for Disease Control, Wellcome Trust, international groups, as well as trying to build something that's going to be meaningful, sustainable, and effective. For NIH right now, there's the RCC in the middle, these community engagement centers. There's our grants portfolio. We're doing supplements. We're helping other researchers that are doing different kinds of research. Is that me? Is my time up? Okay. Doing other kinds of research. We're saying, hey, if we give you some more money, could you include climate change in your work? And we're seeing a lot of folks able to do that. They're able to think about altering their work for it, these P20 centers of excellence, and of course, our other partners. All right, so we've been starting to analyze our portfolio, and we're not that deep. I mean, we have been kind of funding, mostly NIEHS, but other institutes. Okay, 5 minutes, I can pick it up. We have been doing some funding for a while, 2011 to 2020. So you can see here are some health outcomes research, different kinds of health outcomes, respiratory, et cetera. Weather-related concepts, we're starting to understand this portfolio. About 90 of those grants were related to disasters. The occupations most closely evaluated: cleanup, remediation workers, healthcare policy, healthcare police, EMS, firefighters, military, essential services workers. I'm gonna skip this one. So what's the kind of the data that we need to understand, right? I like this, is to me, I'm an old EPA guy at heart in some ways, thinking about that center one, which is the normal risk assessment paradigm for EPA. But what's the etiologic research and risk reduction we need to understand? What are the studies, the mechanistic studies, the toxicology, the modeling, the interventions that implementation science of how we take an intervention and then actually translate it to communities and actually understand if it's good, and then maybe you'll be able to disseminate it to a community with a different cultural background. Same thing on the right side with the risk management and translation, those types of things to change things to regulatory policy, risk communications, health and safety training, recovery, and improved preparedness, et cetera. I'm going to talk just for a minute about some of the NIH funding that's starting to hit the space, especially with a few things like are related to occupational. So we're developing the occupational paradigms. The funding's starting to come in, but here's some examples. So this is a Geo Hub that Fogarty and us and National Cancer Institute fund. This is international with Columbia University, Ethiopia, Uganda, Kenya, and the US partners, focusing on air pollution, cardiovascular function, cognitive development in workers in Eastern Africa. Again, the issue that's been raised here several times about kidney disease and extreme heat. Here's some deep work, right? So now we can think beyond just identifying kidney disease, but what's some of the deeper work? This is a nursing scientist with a K21 award looking at glucose metabolism and heat exposure on kidney disease in farm workers in hot and cold environments. High resolution metabolomics, big data and analytics. We'll look at new early biomarkers in development of acute kidney injury. Cool stuff. Also genetic susceptibility. There's another study by Daniel Brooks at Boston looking at genetic susceptibility in Central American kidney disease epidemic using a GWAS study of sugarcane workers. So we're starting to see the kind of deeper science along with some of the population-based causative epidemiology work that we were seeing, but now combining that. Just wildfire and birth outcomes. Again, this is a study in Alaska, not specifically oriented toward workers, but just thinking about how are these effects affecting reproductive health outcomes in our children and what we're going to see upstream. And this gives me a good segue to this MOccH project, which is a new data integration project that I actually am leading with the team at NIEHS. We've partnered with NASA and we've partnered with the Agency for Healthcare Quality Research to essentially integrate environmental, geospatial data, exposure data, and healthcare records data using NIH cohorts, using large administrative cohorts like AHRQ has cohorts, Center for Medicaid and Medicare Services, those types of cohorts, and trying to think about how do we bring environment, this is Bob's passion, Exposome, bring environment to health. And we have a project to do it. So we are building a web-based catalog and standardizing and linking data sets are going to have some things. But this is all about building a resource. This is not for NIH. This is for the research community. This is building a resource for the research community. And we'll be, tagging a lot of different groups around the country and have been with respect to the project to try to help work together on this space. I just want to mention our NIEHS worker training program. So Ismail talked about his app, which was kind of an app for disaster workers. We have a whole program behind that that actually develops hazardous training for workers across the country in response to climate change. I've been thinking about this for a number of years, hazmat disaster preparedness training program. And we fund folks like Mitch Rosen sitting over here and others across the country to provide training. So NIEHS provides substance and gives us content. NIEHS worker training program for the Department of Health and Human Services provides training, and they use academic centers, they use unions and firefighter organizations to actually take that content and say, how do we make it real? How do we help the workers be safe? And how do we evolve that for climate change and for the other challenges that we're seeing, changes in our materials, changes in our health exposures, and try to produce it not only for an acute emergency, but evolve it over time. Last couple things, these are resources for you guys, if you don't know about it. NIH resource, it's called the Climate Change and Human Health Literature Portal. We've been cultivating articles related to health literature, and you can go on and search this. There's over 15,000 articles. About 4,000 of them are related to the extreme weather events and disasters. As you might expect, it's all over the world. It's global literature portal that we've been producing for a while out of NIEHS. And the last thing I want to mention that Bob mentioned is our disaster research response program. This has been a program that's been in place to try to promote our academic centers, our academic investments across the country from NIH, from CDC and others in a way to produce and contribute their science to these situations. How do we bring the experience, the know-how, the specific opportunities to bring our investments in the academic world to serve and contribute to these situations? East Palestine train derailment, for example, which just happened, and we have academic community contributing to that. This is my final slide. So we've developed a portal here, so it has over 500 survey instruments, things that were used also for the COVID response by NIH. So these are tools and resources to allow the research community to more quickly look and say, what did they do for that wildfire? Oh, who did a survey on that? What kind of questionnaires are available on that? Oh, is it available? Can I translate that into REDCap if you use the REDCap data management system or CDC's data management system? So we have those types of resources here. As I said, we used it for NIH. It was asked to use this for the COVID, and we collected the COVID resources. This continues to grow, but it's a collection of tools for the research community to help them more quickly respond to disasters and to allow us to begin to standardize the way we collect data so it could be used more effectively. If everybody does it differently every single time, we can't figure out and generalize across the studies. And that's what we learned really quickly in COVID. So we have to start standardizing a lot of the work that we do so we can use the data and information. I am going to stop there. Here's some websites. You can also, everything's online. NIH Climate Change and Health will get you a ton of this and link to it. Thank you so much.
Thank you, Dr. Miller. Before you leave this, yeah, okay, some questions.
Give me the hook.
No.
No, I run over.
Okay. We have this question. What glimmers of hope do you have that the NIEHS will be able to seize the current moment? This is post-COVID with focuses on ventilation and with interest in climate change to do more solutions-focused research as opposed to simply furthering elucidating the threats of the environment to health.
Yeah, no, that's exactly what this is all about. So thank you. I mean, I'm really excited about it. As Bob mentioned, I helped co-chair this initiative, but the fact that it's not just NIEHS, we are in partnership with other NIH institutes, including National Cancer Institute, National Institute of Allergy and Infectious Diseases. So the fact that it's being taken up, and I think a lot of it goes to the credit of Rick Roychik, the director of NIEHS, who's really sought to join hands and make this a we, not an us thing. And the ability that the center of that, while it's transdisciplinary science, it's about translation to community. It's about interventional work. It's not about just the etiology and figuring out what's causation. It really is about understanding ways that we can the ways we can respond. Like Rosie talked about heat stress and looking at communities and what could be happening, what greening of environments. But it's in looking at those greening of environments, understanding, is this truly having the intended health consequences that we want it to? And to keep evolving those types of adaptations or those types of mitigations or interventions in ways that they're actually going to be of value to the communities.
We have a question from the audience.
Hi, Dr. Miller. Luz Claudio from here from Mount Sinai. I am the recipient of one of the supplements on climate change and health, so thank you. My question to you is our supplement is on community university partnerships on climate change in international settings. And one of the things that I'm encountering is some apprehension from community, especially communities that are affected by environmental justice issues, in terms of their apathy about climate change, because there's nothing we can do anymore. It's all adaptation. There's no intervention. There's no benefit there's nothing that you can do, basically. And so my question to you is, since you have a broad view of the projects that are going now at NIEHS and NIH in general, what interventions and partnership programs have you seen that have addressed that in a very good way?
Yeah, great question, Lou. I think it's just starting to evolve, right? So I think we're starting to see that. I haven't looked at like the new grants that are coming in, so I'm not as aware of which specifically hit that space. I could probably check on that for you to some degree and get you some opportunity to kind of think of who's doing that type of work. How do I connect with them, and how do we begin to get at it? Some of the issues you go through, the mental health, the solastalgia, the people feeling hopelessness, especially in Native American tribes and indigenous communities, feeling their lands changing, my culture's changing. How do I begin to, deal with that and this kind of slow creep of degradation of what was my heritage, my domestication, my domestic area. So some of that is really going to be needed, and we need that type of work. We're going to have to go much deeper. I mean, we learned from COVID, you can build a vaccine, but if you can't connect with communities and help them to understand how a vaccine can be useful to them, they're not taking it up. And I think the NIH got a pretty good swat about saying, hey, we have to figure it out. We have to go deeper. So hence these programs, the new community alliance engagement centers, I think will be really helpful by starting this ongoing sustainable dialogue with community groups and organizations in this space. Part of their activities is going to be pulsing and working with communities, specifically with what you asked about, Lou, in terms of understanding what is of concern to them and what are some of the strategies that they might suggest would be functionally, culturally sensitive and ethnically relevant to them across the country. So I think we're just beginning to toe in the shallow end here, but stay together.
One of the questions that came in from our online audience, what percentage of NIH budget is climate focused?
Small. we started from tiny. We're to small. I won't make a pitch, but it's growing. But we'll keep our fingers crossed that Congress continues to be helpful, and that we as the community putting pressure in this space and trying to get through what we've been through the past 5-8 years in the country in terms of COVID and political craziness. We need to really address this, and we need to keep the pressure right. It's good having Sara Zaat there and working on policy for us, so she'll get in there and start working on getting us more money for this. Thank you, Sara.
I gonna let y'all do it. There's another question that came in, and this is more along the community lines. How to study and deal with public hostility to government and science.
Yeah.
Talk about the big obstacles as we see with vaccines and COVID.
Yeah, we've got a lot of work to do. There was a space that the agencies and the hubris of the agencies left a wide opening for the political dialogue that's going on right now and the distrust. So we have to learn how to really communicate much more effectively. I mean, as part of this is, not only at the government agencies, but even healthcare providers across the nation. How do we interact with communities? What's fundamental? What does that look like? Bob and I were having a talk just about dealing with IRBs and how we begin to translate. It's going to have to go really deep. I mean, I think there's a lot of discussions about implementation science and what does that mean and what does that look like and how is it truly going to be effective and how do we begin to disseminate it. But, there was a sense about health research in the country is you do it, you put out your stuff from an NIH standpoint, and then the health agency guys would take that and they would translate it. They would take the stuff that NIH puts out, and then CDC and New York State Health and others would translate that. Well, it clearly failed a lot of that in COVID. We had a lot of breakdowns in that. And we're going to have to really think about what does healthcare and public health infrastructures look like in this country. I mean, disasters is a whole nother big issue, is we can't fundamentally fund and put people in the field to look at health issues. The East Palestine train derailment is one. We had CDC go out and do a survey, but we fundamentally don't have the resources, tools, processes, and some of the infrastructure that we need. With that said, I'm glad that we're having this conversation. It's a really important conversation to come back to, and I'm glad that I could be here at Mount Sinai to think with folks here about how do we translate public health and what's it going to look like and what is NIH's role. NIH is fundamentally a funder of biomedical research, but now we are learning that we have to be more than that. And I think we're going to have to grow into these shoes.
Thank you. Let's give Dr. Miller another round of applause.
Thank you.
At this time, I'd like to introduce our next speaker, who is actually Zooming in from Cartagena in Colombia, Dr. Marcalee Alexander.
Give me a minute.
Okay. While Carla is setting that up, Dr. Alexander is the editor-in-chief for the Journal of Climate Change and Health and president of Sustain Our Abilities.
Okay, she's good.
Dr. Alexander?
Hi,
All yours.
I'm here. Hi, can you hear me?
Yes.
Great.
Yes, you are ready.
Hi, thank you for having me here today. I'm honored to be speaking at this meeting and also that you'll accommodate the fact that I happen to be somewhere else today. What I'm going to do is share my screen right now. I ended up with some technical difficulties in my computer, but it seems like we've worked it out. So I'm just going to start my slideshow. And really, are my slides? Okay, the slides look good.
Looks good.
I'm happy actually to be joining you. My talk is going to be, I think, a little more grassroots oriented and picturesque than our previous speaker. But I think there's a lot to really think about when we start talking about the nuances of disability and rehabilitation and climate change and health. And it kind of parallels my own career. And so I'll even mention what happened there. But these are my disclosures. I am the editor of the Journal of Climate Change and Health. And I ended up along the way, in my desire to work in climate change, I ended up feeling like I was obligated to start a nonprofit, which is called Sustain Our Abilities. So my career, just to mention, the last time I really gave lectures at Mount Sinai, I spent a weekend talking about sexuality. And I've had a lot of NIH funding looking at sexuality and, in fact, spinal cord injury. But I did the GORE training back in 2007 and said, you know, I really want to work in climate change. How do I do this? Well, it's been a process, it's been a journey, and I will share a little bit with that with you today, but I'm also going to be talking about what physical medicine and rehabilitation has to do with climate change, disability and climate change, and actually I hope I can give you a framework which will allow you to see how we can't just think about disability and climate change. We really need to get into the details. Just like you can't just talk about cancer, you can't just talk about disability. And I think this is something that physicians and researchers need to consider regarding disability, health, and climate change. And I actually think there were some nuances, which I will bring up too, as we talked about the public opinion. Because as I've been on this journey, which has been going on about 5 years now, looking at climate change, disability, rehabilitation, and health, there's a lot I've been learning too about the politics and the people. So physical medicine and rehabilitation, for those of you that don't know us, and actually that's still a lot of people in the world, is we are a multi-specialty field, and climate change is going to impact all the aspects of our field. People work in outpatient orthopedics, sports medicine, people work with degenerative neurologic conditions, medical rehabilitation. There's a whole big area of pediatrics, adolescents, neurologic disorders. So many people have strokes. And then there's the more serious disorders, traumatic spinal cord injury, which has been my background, spina bifida, TBI, amputations, acute and chronic pain. And then there's the area of PM&R, which very few people may specialize in, but that's more functional prognosis, recovery of function, and yes, even sexual function. The thing is, physiatrists have been late to the game of talking about climate change. Being an early adopter, it took until actually 2019 for me to get a course accepted at a professional meeting of physiatrists. And so when I finally was working on a lecture, I'm like, okay, well, I want to give a picture of people with disabilities in disasters. So I start looking for wheelchairs and disasters. And what I found was 209 pictures of dogs and no one with disabilities. So this is not an issue that people actually look at in terms of disasters or climate change. So the question was, what do people with disabilities say? And as part of that, I think you did have a video shared with you from YouTube. What happened was I started a walk. I started a walk from Canada to Key West with the goal of, number one, finding people with disabilities and asking them what they think about climate change. And number two, bringing my message to places. So I actually walked from Canada to Manhattan and have given grand rounds previously at Sinai looking at disability and climate change. And we did a couple of other things along the route that you'll see as my slides move forward. Now, the thing is, when you think about climate change and disability, you can't just look at it from the medical model. When you work on climate change and disability, and this is what I found on my walk really is, I may be a healthcare professional that wants to talk about climate change and disability. And I'm like, oh, well, this should be easy. I'll just talk to people in the disability groups. I'll talk to the people in environmental groups. I'll pick up the phone. I'll try to get people together and I'll get support. Well, no, it doesn't happen that way, does it? What I've really found in working more closely with the disability field is that it's actually very similar to issues related to sexuality, in that there are common effects and there are specific effects. And there's the medical model and then there's the social model. And people working in the social model really do not want to necessarily include some of these medical nuances. And there's a reason for that. And that's because historically, the medical model has not really been something that people in the disability community have felt that they've gotten support from. So what I have done over the past few years, actually with Sustain Our Abilities, is what we've done is bring together people in rehabilitation, meaning physicians, meaning nurses, meaning therapists, and people living or people with the lived experience of disabilities from around the world. And we're trying to work together to work on climate change and disability. So this slide actually is a slide of my deputy director, Alex Guinness, who lives with a spinal cord injury, but has a background in environment and in policy. And so when you think about climate change and disability, and I'm going to give a couple different models here. So what I want you to take from this is that we've got to be sensitive to, number one, the issue of climate change and disability, but we've also got to start working on a medical framework in terms of this, in terms of the research aspects of things. So if we think of climate change impacts, we've got the impacts listed: extreme weather, can be general, specific. We can have infrastructure problems. We've got the economic consequences, government issues that can happen. We will have uninhabitable areas, dislocation issues. We've got to think about migration, which hopefully would be proactive, the disease issues, and then social upheaval and conflict. And then think about the disability factors, though, that there are. Disability can have broad categories: mobility disabilities or intellectual developmental disabilities, specific disabilities, MS. That's a specific disability with a whole huge population and different issues going on. There is the use of and need for government services, medical care, attendance, housing needs, mobility, transportation, economic barriers that people with disabilities have, and then they do have some opportunities. And then there's the intersectional factors such as race, income, etc. So you may still think, okay, there's a lot going on. And why do we have to think about it? Well, climate change does disproportionately impact people who are differently abled, the elderly, poor, people of color, and indigenous populations. Yet I still feel and see that people who are differently abled are often the least acknowledged. People who are differently abled are especially vulnerable in extreme weather and have some nuances which make them different. There's a need for assistance from others, inability to stay in a cramped environment many times, and there's lack of early warning systems. And the other thing that I really try to drum into my physiatry colleagues is that in crises, people prioritize themselves. And there's an example of a woman in New Orleans during Katrina, who was, her ride canceled on her. She couldn't get to the shelter because they wouldn't take her wheelchair. And ultimately she died when she was on the phone, when the dam burst. So why do we need to work on this? Well, if we take this slide here showing climate drivers, and this is, it's a couple years old, but it's still recent, you can see that there is nothing in terms of ability on this slide. We might talk about pre-existing health conditions, but when you think about disability, it's really not a health condition. So we need to think about ability. And the other thing is, when we get older, this problem is going to be worse because the older we get, the more problems we get. And obviously, we know that disability is much greater in the elderly population. So, practically speaking, how do we now see climate change impacting people with disabilities? Well, this is one of the 2021 hurricanes. I was working by chance in New Orleans. And these were 3 of my patients that came in around the time of the hurricane. First patient, I have a woman being admitted to rehab who just had spinal surgery. She had lung cancer that was metastatic to her spine. She had the surgery on a Tuesday, and the projections were for the storm to come in on Wednesday. And they actually had discharged her to a shelter because she couldn't go home. There's another 58-year-old I had with an AK previously. And on her, she stayed at home during the hurricane, no place to go. Well, during this time, with no power, nothing else, she ended up becoming septic and required an AK on the other side. And then I had a 39-year-old with a second stroke timed with the hurricane. So people with disabilities are essentially very vulnerable during these times. This is not all the patients I ended up with after the hurricane, though. So many people with disabilities just end up in the ER when there is a hurricane problem. And actually, what happened with me where I was these people ended up in rehabilitation as patients in rehabilitation because they had nowhere to stay. So this is if you're thinking about costs of climate change and health, this is an area where there are actually funds that we are not properly spending because we don't have shelters that are accessible. A great need we have. So there are common issues in regards to climate change and disability. And those common issues include the people's double risk in regard to need for migration due to temperature and flooding. You can have a disability, but also live in a flood zone or an area where there's excessive heat. And certainly this is an international problem too, not just a US problem. I think when we talk about climate change, we have to think international. Impoverishment, certainly people with disabilities are more likely to be unemployed. This can prevent people from being able to control their environment. and people with disabilities are more prone to dual diagnoses such as depression, pain, and addiction. Being inclusive of people with the lived experience of disabilities, though, is very important. And this woman in this picture, Gretchen Dillon, she's from Puerto Rico. She happens to have a spinal cord injury, but she's also a psychologist. And during Maria, she helped other people. One of her quotes is that people were sharing their catheters. She went around the island and was helping people. Well, there were no catheters, so they had to share. And the video that I shared also has a lot of, not a lot, but a number of people from Puerto Rico talking about their experiences during Maria, also other countries. If we start, though, to get more into the medical model, we start thinking about specific disabilities and how climate change is impacted. This is a study I published a few years ago. It was just a survey, but I think it's a really important disorder to think about in terms of disability and climate change, because people with spinal cord injuries actually have a lack of temperature control. Well, how much more can we say about climate change and spinal cord injury then? They're susceptible to extreme heat. They're susceptible to extreme cold. They have problems with pressure ulcers they can get. They've got neurologic issues such as neuropathic pain, which gets worse in the heat sometimes. They need the paid assistance and equipment. They have bladder and bowel incontinence. In this population, 57 professionals already felt climate change had impacted their patients' health. There are also special concerns with sensory disorders. Think about having a brain injury, autism, having difficulty with awareness of disasters if you can't hear, can't see, inability to be in a cramped shelter, need for powered devices can happen too, caregivers, transportation, and then we've all got our individual needs. Now, the point I want you to get here, though, is that spinal cord injury is very different than having a sensory disorder. And there is a not a large, but there's a growing contingency, and there is a now acknowledgement of the issue of people with disabilities at the COP levels, et cetera, and at the UN level, with the UN just named disability a human rights concern with regards to climate change in 2019. But when we think about disability, we have to realize there's many different disabilities and people's functional needs are different. And then the problem we have in terms of public health is people with disabilities don't live in groups. There's not a town of people with disabilities that you can go to when you take that community-based approach. And this does create difficulties when you're looking to get funding for different areas, because they look to communities and people with disabilities just don't fit in. So you've got to think of all these other concerns: physical, motor, sensory, emotional, cognitive, functional, medical, equipment, and the fact that people with disabilities often have multiple concerns. So if you take Alex's model of weather and disability categories, you can see you've got climate change impacts and disability factors, and you can dig deeper into this. If you look just at more extreme weather and the broad categories, you will see you've got so many different relationships, again, to think about just in terms of extreme weather and disability. Hence the reason not to clump people together in terms of disability when you're looking at research. So you've got all these types of extreme weather and all these types of disabilities. And one of the things we're hoping to be able to do and looking into being able to do is doing a prospective study looking at people in different countries with different disabilities and directly querying people with disabilities in a mixed methods approach about what weather event have you dealt with, what is your disability, what are the impacts and the solutions to that specific problem. When we think about disability and climate change, we also need to think about inclusivity. And we can think about inclusivity in terms of mitigation and adaptation. One big issue in terms of inclusivity is the issue of creating bike lanes. Well, bike lanes are great, but they also need to be useful for people that are wheeling or walking. And that is part of why I'm continuing my walk as we go on. And I'll share a little bit about that too. So just a couple slides to just talk about PM&R. Not only does PM&R work with people with disabilities, but also endurance athletes in climate change. And this is a study that was published in our journal, looking at what are the issues in endurance athletes. Okay, well, think about endurance athletes. You've got heat-related illnesses. You've got to have advanced planning. You can think about tick-borne illnesses if people are extreme athletes and how environmental impacts will affect them there. We've got the need for mitigation strategies for the people that are going to experience these things, although that's not really the greatest use of the word. And then we've got to think about the temperature increases and particulate matter and what that will actually do. And then, you know, what can you do in terms of the pulmonary disease that will go on in terms of the air quality? And these slides are courtesy of my colleague, Adam 1040, who's a writer on that paper. So we can look at rehabilitation, we can look at disability, and we can see how there's a need to deal with specific aspects of disabilities in terms of climate change, but there's also general issues. So what I want to do is take this out of the field of PM&R and just kind of summarize things in a more general health issue. So as was said, I do edit the Journal of Climate Change and Health. And there's an editorial which I really like that was published back in 2021, where we talked about what providers need to be. And when I think about the issue of climate and health, I really feel like, you know, climate and health needs to be part of medical school training, residency training, and general doctors' practices. We've got to start thinking about climate and health like we think about cigarettes. And so we think seeing clear is a great term for people to use. We've got to be communicators, climate leaders, educators, advocates, and researchers. And I'm just going to touch base here on advocacy and research. Now, the question is, how do you become an advocate? And I'm just going to say this is a just do it approach. This is really the grassroots approach. This is me in this picture. Back when I started realizing I needed to speak to people and do something radical to get people in rehabilitation to work on climate change and disability, I decided I was going to walk from Canada to Key West. And in this picture, which is at the Trade Center in the former Trade Center area in the Oculus, we had an event, and seated in the wheelchair is Victor Calisi, who was the Director of Disability for New York City. And this person here is Deanna Criswell, who at the time was working at New York, and she's all at FEMA now. So we had an event there, and these are a couple other city council persons in the picture. We had a walk. We ended up going down the west side in, I guess it's the Green Path, and tried to bring attention to something called Day for Tomorrow. This is in Philadelphia. Now, the idea here in terms of advocacy and Day for Tomorrow is that it's not just enough to have Earth Day. We need to think about people too when we think about climate change. And I think this is one of the solutions for getting the political issue at least starting to be dealt with. It's that disasters strike. And when you have disasters, your neighbors are crucial. You can't rely on EMTs totally, EMS. You can't rely on the police. You've got to rely on your neighbor. And if you have a disability or your neighbor has a disability, it's a good idea that the person knows that. The other issue, which really relates to why I'm going to continue to walk, is what I've learned walking down roads, and I've walked in North Carolina thus far, is, you know, our roads suck. You can't walk on our roads. The only way there's roads is if they're in front of establishments where you spend money, or specifically in towns. Other concepts are that financially driven schedules increase people's stress. Our built environments force use of fossil fuels. And the concept of Day for Tomorrow really is to have people start joining together in community and promote a healthier landscape and environment where we can conquer climate change. So I'm going to be done. Here is a Day for Tomorrow event in Africa that was held. And we also have started a healthy environment letter, which you can sign and take. And I am going to be walking. I've changed the name of my walk to Green Route Aiding Healthy Adaptation and Mitigation from Rocky Mount to Key West this year. So just some final points. What could we research in terms of dealing with disability, our consumption, sustainable therapeutics, telemedicine, tracking devices, decreasing polypharmacy, integrating holistic care, systems for cooling and heating, biodegradable catheter supplies, recycling equipment, and plant-based diets, all things that could be done. There were some talks that were relevant to articles that are in the Journal of Climate Change and Health, and I would strongly suggest you all follow the updates. Since the journal is gold open access, all the papers are free to read, and actually there is a paper on the billion-dollar disasters. And I'd like to invite you all to Climate Health 2023. This is a meeting we're having. Emily Sinai, Dr. Sinai is part of our group. And one of the highlights of this is we're going to be doing deep dives into various medical specialties, looking at scoping reviews and trying to get a different viewpoint of climate and health. And this will be hybrid, of course. It's going to be held at Hofstra in fall. So thanks for listening to me. And I hope you'd like to learn more about SOA and trying to bring community together with professionals and looking at climate change and health. Thank you.
Thank you very much. Let's give Dr. Alexander a hand. So now I would like to introduce you to our next speaker, who's going to talk to us about the solutions and plans to make NYC more responsive and protective of workers, Daphne Lundi. Daphne joins us from the New York City Mayor's Office of Climate and Environmental Justice, where she is Deputy Director for Living Streets and Public Space Programs. Please welcome Daphne Lundi.
Good afternoon, everyone. As mentioned, my name is Daphne Lundi. I'm with the Mayor's Office of Climate and Environmental Justice. And for folks who aren't familiar with us, we are essentially the city's climate policy shop. We're really lucky to get to work with a lot of health professionals on a day-to-day basis and also work with scientists to help us sort of shape our work and understanding of climate risk. So I'll be talking a bit about how we think about the intersection of transportation and public health and how that's been baked into a lot of our climate work moving forward. And I also just have to say I'm really thankful to be following Dr. Alexander, because I think she really highlighted a lot of the ways that we need to be thinking about climate and health from this holistic perspective. So understanding the fact that for some communities, some populations, there are these compounding issues, and unless we have a really important grounding in that, we're not doing the policy work and action that's really necessary. So I don't think I have to explain to this audience the connections between climate risk and public health, but I'll say that this graphic and framework is really helpful for our office. And so when you think about climate risk, it's really thinking about not just the hazard itself, but the fact that there are oftentimes these rippling effects that happen as a result of an event. So for example, if we look at extreme heat, it's not just about thinking about the heat wave itself, it's also thinking about things like how a heat wave might trigger a power outage, or how if someone has health issues, they might be experiencing a harder time breathing because of the poor air quality from that heat wave. And then with a lot of these events, we also know that there are oftentimes longitudinal impacts. So if you're somebody that's experienced several hurricanes or several heat wave events, we know that people often struggle with PTSD, anxiety in the long term. And so again, unless we're thinking about this wider aperture of issues around a climate hazard event, it's really hard to be addressing sort of the root causes and developing the holistic solutions that we need. So we are lucky to have a body that's known as the NPCC. This is the New York City Panel on Climate Change, and their science really helps to inform the direction and focus of a lot of our work. So when you think about the future and what New York City looks like, we're expecting a future with more heat wave events, as well as a future that has more precipitation events. So by 2030s, we're expecting a tripling of the days over 90 degrees. And then over the course of the century, we're expecting an increase in annual precipitation. And just to go back to that previous slide, if we're in a future where there are more heat wave events and more flooding events, that means that those compounding issues I laid out are going to be faced more frequently. And so there are basically more moments where somebody might be experiencing those short, long-term, and then longer-term impacts because of the climate event. To zoom in on public health and transportation, a lot of the understanding that we have around those intersections comes from our city's health department. So one of the things that we focus on really importantly is the concentration of PM 2.5. As this group knows, it's one of the particulate matters that's most of concern because of the ways it can really enter our system. And so when we look at the landscape of emission sources in the city, 50% of those particulate emissions come from buildings, but there's also a significant portion of those emissions coming from transportation, specifically traffic. So these are our trucks, our personal vehicles, the particulate matter that's generated from those. And so when thinking about our solutions, we're really focused on ways that we're addressing emissions from buildings, but then also thinking about the spectrum of other emitters in the city and how we can address that through policy. We also know that these impacts are not felt evenly. And a lot of this is tied to histories of racist policies like redlining, the ways that we've built our highways and transportation systems, and the fact that certain communities have experienced these decades of disinvestment and environmental racism. And so when we look at trucks and buses and the particulate matter from those emitters, we see that certain neighborhoods experience those exposures a lot higher than others. So for example, if we look at trucks and buses, we can see that in the South Bronx, parts of central Brooklyn, there's a much higher concentration of that exposure. And a lot of that is tied to the fact that neighborhoods like the South Bronx, Red Hook, are areas where there are lots of warehouses because of delivery and e-commerce. And so these are neighborhoods where more and more trucks are traveling through those spaces. That's, from one perspective, a safety issue in terms of how people get around, but it's also an air quality issue as well as an issue when it comes to our greenhouse gas emissions. And then what we also know is that there are neighborhoods, particularly low-income neighborhoods, where these levels are experienced far higher. And those are the same neighborhoods where we see the increase in hospitalizations. Typically around a couple thousand people are hospitalized directly because of these emissions on an annual basis. So one thing that is really special about New York City is the fact that when it comes to transportation mode share, we're actually a quite sustainable city. About 65% of our mode share is sustainable. So that's people that are walking, taking the subway, using their bikes, all of the ways that we sort of move around the city. But there's still a pretty significant portion of our system of people who use vehicles as their primary mode of transportation. There's lots of reasons for that. There are parts of the city that are in transit deserts. There are people who use their vehicles for work. And so while we are a pretty sustainable transportation mode share city, we want to be trying to find solutions that support that transition and support the reduction of emissions from that sector. So our main policy document has really been the development of Plan NYC. For folks who aren't familiar, this is the city's climate strategic plan. It's mandated by local law. So every 4 years, there's a climate plan that's developed by the city. We just released our first climate plan under this admin this past Earth Day. And the sort of scope of it changes from year to year, but there are key sectors that the plan has to look at. So it has to look at the impacts of things like open space or transportation, water quality, climate change resiliency. And through the course of the plan, it's really meant to lay out what are the policy directions, what are the actions, what are the initiatives that the city is doing to address all of those areas from a lens of climate and sustainability. And another part of the plan that's really important is that there's also key indicators and reporting as a way of keeping us honest, basically, to ensure that on a year-to-year basis, we're really able to speak to how we're addressing those issues and then making progress over the course of the plan. So I won't go into all of the sectors of the plan, but if you want to read more about it, I suggest going to our website. But I did want to highlight the framework of the plan and how we really tried to make it a document that was accessible to everyday New Yorkers. So, because I'm in an audience of scientists and medical professionals, we love working with you all, and we think that the science and projections are really important. And in thinking about how to frame this plan, we really tried to think of how we distill this work into a perspective that is accessible to everyday New Yorkers. And so we really tried to focus this work in 3 clear buckets. How we're protecting New Yorkers from climate threats. So this is where we outline what we're doing around extreme heat, flooding, helping to decarbonize our buildings, improving quality of life. So these are initiatives that are focused on making it easier to move around the city. So how we're addressing open space or transportation, thinking about our food systems. And then lastly, we focused on building the green economic engine. So with all of the work that needs to be done, how are we connecting people to green jobs? How are we addressing our waste systems? How are we supporting a circular economy that's more sustainable? So this was really the lens that we used to lay out all of the sections of the plan. And again, there is a lot of science and information and policy that's baked into this, but we really tried to think of language and framing that would help a regular New Yorker understand what the city was doing, but B, help them understand how they can either plug into that work or support that work or know how that work is being developed. So when it comes to transportation, our big sort of pillar of this section is thinking about how we're reducing emissions. So we're thinking about emissions both from the perspective of greenhouse gas emissions, but also from the perspective of improving quality of life and the cleanliness of our air over time. So the big goal that we've really laid out is reducing our transportation emissions by half by 2030. When you look at the landscape of greenhouse gas emissions, the primary driver of those GHG emissions are actually from buildings. So about 70% of our greenhouse gas emissions come from buildings, but the remaining 20-30% is largely driven by transportation. And so in the ways that we're working to reduce those emissions from the perspective of addressing climate change, reducing those emissions also helps us with things like air quality, livability, making it easier to be in the city over time. So this section had 4 main pillars, and I'm just going to sort of go through all of them one by one. A big driver of this section was thinking about ways that we're helping to reduce the amount of trucks on the city streets. So as I mentioned, we know that the landscape of air quality in the city is not equal. A lot of this is driven by the change in shopping patterns that we saw during the pandemic. A lot more people bought things online. E-commerce exploded. And so what we've seen is that there are lots of neighborhoods where there are huge concentrations of warehouses and what are known as last mile delivery facilities. So these are the places where, Amazon, UPS sort of drops their goods as the last stop before they get delivered to somebody's home. And so a big thing that we've been working on is thinking through how we're diverting as many of those trips as possible to other modes, be it cargo bikes or electric trucks, and then also thinking about ways that we can be encouraging and enforcing lower emission in certain areas. So one of the things that we're developing over the course of a couple of years is a low emission zone, particularly focused on those areas where we know air quality is an issue. And how that work would really function would be that if you're in an area that's designated as one of these zones, there would be requirements on how you as a truck or fleet owner would have to navigate that space, really trying to encourage, again, this alternative way of delivering goods or thinking about ways to support more electric trucks over time. Another thing that we've been doing is thinking about ways that we can have alternative modes of delivery and getting things and goods to people. So another part of the plan is thinking about how we can be supporting a marine highway as a way of, again, diverting things that might happen on trucks to things that might be able to get to us by boat, and thinking about ways that that's then improving the local air quality in particular neighborhoods. We also wanted to use this plan as a way to support and prioritize public transportation. Probably unsurprisingly to a lot of folks in the audience, there was a massive change in how people got around in the city. As a city, I think we're still trying to get back to the transit usage that we had before. And so a lot of this plan is thinking about how do we encourage and support people to take the train, take the bus, walk around, use bikes. And a big part of this is really thinking about how we're redesigning our spaces, our streets, to make them more accessible and a better option for folks who want to, perhaps get out of their car and use other modes of transportation. And another big part of this has been thinking about how we improve the cleanliness and design of our streets in general. So some of you might have heard about the containerization study that was done by our sanitation department. And a big part of that is thinking about how we clear out our sidewalks and how we make space for more efficient waste systems. And then in doing that, that opens up more space for people to walk around. It opens up more space in the streets for things like bike lanes and other modes that really prioritize pedestrians and people. Another thing we wanted to work on is increasing the accessibility of bikes and scooters to people. So, we've had a pretty robust bike lane system for quite some time, but we know that there are things that we can be doing to improve them and think about the next generation of bike lanes. And so one thing that we've been doing is really retooling our bike lanes and our bike systems to support things like cargo bikes, or to support things like wider bikes, just so more people can get around. And so that's been part of what's been baked into this as well. We also know that part of why some people don't choose to bike is because it's hard to find a safe place to lock their bikes. And so another thing that we've been developing is more bike parking opportunities. So if you're somebody that wants to move around, but you're afraid of, losing, possibly hundreds of dollars because your bike might get stolen or broken, we're really trying to think about ways that we create safer bike parking options for people as well. And then for neighborhoods that are, farther from transit or farther from buses, we're also trying to think about ways that we can expand scooter or other types of systems as well, as a way to make it easier to get around. Our Department of Transportation has had a pilot for the past couple years in Southwest Brooklyn, or Southwest Bronx, a place that's harder to get to by train. And it's been a way to encourage and just provide more options to people that are trying to travel in that part of the borough. And then lastly, we wanted to support drivers who have to drive by helping them have more options to drive electric. So a big part of what we're doing in this space is developing the infrastructure to make it easier to charge your vehicles. A big thing that's never happened before, and I hope it happens again, but it's never happened before, is the amount of federal dollars that we're seeing from the federal government to support things like heat pumps and electric vehicles and that kind of infrastructure. And so while we know that this is helpful for the purchase of e-vehicles and for the purchase of those technologies, we also know that there needs to be the infrastructure to make it easier to charge your vehicle, whether it's a personal vehicle or if you're somebody that uses your vehicle for work. So that's the type of infrastructure we're going to be building out over the next couple of years. And then lastly, a big part of this work is making sure that the city is not in the way. So one of the things that we've just launched is a zoning change that's called City of Yes, zoning for carbon neutrality. And one big part of that is basically incentivizing and supporting more charging facilities for vehicles in commercial areas of the city. So that's another part of that work that we've been developing. So just to distill a lot of this, I think this audience already understands this, but just to emphasize it, what we know is that climate change is really the health threat multiplier. So in a given day without the risk of climate change, we know that there are certain people and certain communities that have long understood health disparities. And so with climate change, that's just another layer of risk and vulnerability that's layered onto that work. Oftentimes, medical workers are the trusted messengers for a lot of this work. You are seeing people on a one-to-one basis, or you're working with communities in such a way that we may not be able to reach as policymakers. And so it's to the extent that you can think about those relationships as another touch point to share that information, I think that's another way of just helping people understand the risk and how it's connected to personal health. And then, lastly, you might be asking, like, how does this policy connect to our work, or how does this policy connect to what we think about? What we know is that transit-oriented development is really critical. It's critical from a sustainability perspective. It's critical from a social cohesion perspective. And to the extent that we can continue to be in partnership and see public health professionals as folks who are also advocating for those types of initiatives, that's the type of work that is really critical for this holistic climate change and public health work. And that's all I have.
Thank you very much. Because of time, we're going to keep moving.
Okay.
Ms. Lundi's information is on the internet, so if you have questions, I do have one. Wait.
Oh, okay. Cool. Yeah.
All right. One of the questions that came in was, does your office, OCEJ, work with HHS or federally qualified health clinics in New York City on sustainability efforts and/or resilience planning? And the second half, and our clinical practice transformation to climate smart healthcare.
Yeah, so we work with HHS through our health department. So we're really lucky in the sense that our health department has a Bureau of Environmental Surveillance, and I'm blanking on what the P stands for, but it's called BESP. And so they're really a group of folks who are working at this intersection of public health and climate policy. And oftentimes there are conduits to work with OTDA, which is sort of the state arm of a lot of our health work, and then also with HHS. And they've been really critical with a lot of advocacy work, particularly around things like energy efficiency and energy insecurity, because we know that there's a really deep connection between extreme heat, how people die in the summer, and the fact that it's oftentimes tied to people not being able to afford to turn on air conditioners or cooling because of utility cost. And so they've been a really helpful partner in making that connection between public health, energy, clean energy, and utility assistance. And we've really looked to them as those advocates in that space.
And lastly, a lot of the vehicles of the city, the transit, the police vehicles and everything. Any word as to when they'll become electric?
Yeah, so our DCAS, which is the Department of Citywide Administrative Services, they are in charge of our city's fleet, and there is a target around electrifying our entire city vehicle fleet by, I want to say 2035, but for more information, feel free to reach out. But we do have a target around that. I think we've already gotten really far already, but there are just some vehicles that are harder to electrify because they're bigger. So as the technology gets better around things like sanitation trucks and bigger vehicles, it's going to help us reach that electrification target sooner.
Is there a question from the audience?
You had spoken about changes in transportation patterns as a result of COVID. How, and if it all has, I know many people have no choice, but there's many people who have the opportunity to do remote work. How has that changed? Or are we pushing for more remote work for people who can do remote work on a city level?
Yeah, so I think that part of the change has been remote work, but we do know that there's a correlation between class and who has the ability or luxury to do remote work. So a lot of the neighborhoods where we see the higher vulnerability to extreme heat or the higher exposure to PM 2.5, oftentimes those are the workers who don't have that option. And so that's kind of part of why we're thinking about this in a holistic way. Like, there are some people in the workforce that will be able to do that. But for the people that can't, that's why we're thinking about supporting electric vehicle transition, building the infrastructure, and then also thinking about things like biking and other modes of transportation as well.
Another question from? from the audience? Yes, Dr. Claudio.
Hi, my name is Luz Claudio. I'm a member of your Environmental Justice Board. And as you probably know, we've been doing listening in to the communities about environmental justice. And one of the topics that have come up a lot has been on the trucks that come from outside the city. I don't know if you have a plan about that, but it's an issue that comes up a lot in our listening sessions with the communities. Do you have a comment on that? And
Yeah,
thanks.
thank you. So there are a couple of ways that we're working to address that. One way is just making the transition easier for fleets. So our Department of Transportation has this program that's called the Clean Truck Program. And what it's really meant to do is make it easier to cover the cost of trucking to make that conversion. A big part of the challenge is the cost. I think right now the cost of an electric truck is somewhere in the hundreds of thousands. And so we're trying to make it more affordable to do that as a way of minimizing the emissions exposure that we know exist. And then, another big part of this is trying to minimize how much trucking happens in the city because of the explosion of e-commerce that happened over the pandemic. Something like 90% of goods that come into the city are coming on trucks. And if we're able to just change a fraction of that or more than a fraction of that, that's again another way of trying to address the air quality issues in neighborhoods in the city.
Yes, Dr.
In the planning, is there a visualization of what this might look like as these changes are made? And what about walkability? The bike lanes are great unless you're a pedestrian. So what about the lowest of us who use our feet to get everywhere and are concerned about the quality of the sort of crazy that's on the street with everything everywhere all the time and really having to be thoughtful and careful? Is that included in the plans going forward?
Yes, and I wouldn't call pedestrians the lowest of us. As a happy pedestrian too. So just for the sake of time, I didn't zoom into it, but under this administration, we have a new position that's called the Public Realm Officer. And a big part of that is trying to reconcile all of the uses that are happening in the street. So it's the people on bikes, it's the people walking around, it's the cars, it's the trucks, and really trying to reconcile that. So there are clear targets around that, not just around bike lanes, but also just improving mobility as well in the plan.
Okay, let's give Ms. Lundi a hand.
Thank you all.
Now, I'd like to introduce our afternoon panel, which is focused on how clinicians across specialties must develop an occupational health lens. Our presenters are Dr. Pune Sabiri, Adjunct Assistant Professor of Biomedical Sciences at Cooper Medical School of Rowan University, Dr. Valerie Mack, Epidemiologic Intelligence Service Officer for the U.S. Virgin Islands Department of Health, and Dr. Karen Solomon. Dr. Solomon is the Deputy Editor of the New England Journal of Medicine and Associate Professor of Medicine at the Harvard Medical School, Brigham and Women's Hospital. The panel will be moderated by Dr. Perry Sheffield. Dr. Sheffield is an Associate Professor in the Departments of Environmental Medicine and Public Health and Pediatrics here at the Icahn School of Medicine. Dr. Sheffield.
Thank you, Dr. Thompson. Greetings, everybody. As faculty here at Mount Sinai, and it's my pleasure to moderate this last panel of the day. So welcome, everybody. We're going to have a conversation. The way we'll generally structure this is the panelists will make opening remarks, and then we'll have a bit of a discussion up here and open it up for Q&A for some participation from you all. Our panel, our charge for the next little while, as we're spending this last session today, is talking about developing an occupational health lens for clinicians across medical specialties. I think of this as us thinking together about how climate change is relevant to each of us. So in that spirit, before we go to our opening remarks, I wanted to, by a show of hands, ask the audience, because I have gotten the feeling today, those of you I know and other questions, that we are clinicians, we are researchers, we are students. Most of us work probably in climate-controlled settings all the time. But I want you to raise your hand if you don't, if that falls outside your realm, if your main occupation is outside of a climate-controlled setting. Probably nobody, but I thought maybe. Okay, so, but who has a close friend or family member to whom that applies, who works outside in a climate? Keep your hand up. Okay, so that's a few of us. Okay, yeah, keep your hand up. And who knows someone or lives yourself, sleeps in an environment that is not climate controlled with no AC? Keep your hand up for if you, any of these categories. Okay, who takes public transportation to work? Getting more of you all. And who has hobbies that take them outside? So sort of your extracurricular outdoor activities. This kind of counts too, particularly if we think about children and sort of their occupation and sports as their occupation too. So you started to see, if you looked around, that really, by varying degrees, affects all of us. Whether it's through heat or outdoor air quality, certainly there's a disruption of systems or other climate impacts. So welcome everybody, and I think we'll just go from the far end down, starting with Valerie, then Pune, and then Karen, for your opening remarks, and then we'll jump into the discussion.
All right. Well, it's really wonderful to get to be here, and I've met a few people just through brief conversations today, and I've also been trying to look for the nurse badges, but I feel like people walk extremely fast in New York City, so I haven't been able to catch up with all the nurses I wanted to greet as well. But actually, I finished my time as an EIS officer in U.S. Virgin Islands, and now I'm actually an epidemiologist there. And before that, I did work in academia, so I've had the pleasure of working in clinical settings, academic research, and then now public health as an epidemiologist, which I do feel like when I first started working as a nurse, I knew that the epidemiologists, they would call people after an STI diagnosis, and that was about all I understood about epidemiology. And then later on in school, I learned about surveillance, but until I actually worked in a territorial health department, I didn't really fully understand how clinicians and epidemiologists work together. And we're also a very community-based health department that faces a lot of climate issues, and it's almost like it's a lived experience on a daily basis. And so for me, I have a lot of things I would love to share about that, but also want to make sure that the audience here, especially knows with all these medical students and people who are early in their careers, is that, you know, you probably already heard that CDC has made giant investments in this last year in these workforce development grants, along with data modernization initiatives. So there's absolutely no better time than for clinicians to be speaking more closely with epidemiologists and those groups also working closely with researchers, because that implementation science that we're speaking about and like what we're asking about as far as like how do we bring this research to communities and make it effective with like face-to-face interactions with community health workers, with people actually doing the day-to-day work, because each community is completely different. Even if you try, you cannot categorize communities. It's each individual community, but that's my encouragement for you, that it is a challenge. And just like what Ms. Lundi was saying about heat being a multiplier, I also worry it's a multiplier for access to care issues. But that doesn't mean that we're in a hopeless situation or in the perfect time, I think, for this. And one thing about COVID and the US Virgin Islands is that it actually put public health and epidemiologists much closer to clinicians, because we were handing out COVID-19 testing kits. We were like working on MOccH kind of interventions right after COVID-19. In the USV, I'll brag about the health department. There was COVID-19 reports every single day for over 2 years. We just switched to weekly reports maybe last month. And so I think in a lot of ways, we're at the perfect time, the perfect opportunity. So please don't be discouraged, and know that anything you do right now, I think you'll still have lasting effects.
Thank you.
Great. I think we'll share.
Hi, everyone. So as you heard, my name is Pune Saberi, and I'm very excited to be here today to tell you about this project that we've been working on. And I know that the focus of today's conference is on clinical care for workers, but I feel strongly that the tools I'm sharing will have utility for any clinical scenario in this climate crisis. So the inception of the creation of these tools, it started with this simple question. One of my students asked, well, what is the point of entry for a clinician about climate change and its impact on the patient's health? And that's a very, very good question. You know, how do clinicians enter this field? The current literature currently indicates that health practitioners are concerned about how climate change affects health, but may not have the tools to translate that concern into clinical assessments. And then most of the existing training is knowledge-based, but it's not skills-based. And then currently, at least to the best of my knowledge, there are not established mechanisms to track how health is impacted by climate change except through modeling. And I'm really glad to hear about all the research that's happening, but to the best of my knowledge, that's how I see it. Now, putting all that together, offering these tools, we can provide practitioners a potential way to assess and document the climate impacts, as well as collect information from the medical record. I'm actually, oh, it's up there. All right, fantastic. All right, thank you. Just occurred to me. I worked very hard on this slide, by the way. I'm an occupational and environmental medicine physician, and the current struggles with establishing climate health impacts reminds me of the same barriers that we faced with environmental medicine. For example, you might agree that environmental medicine is highly knowledge-based, whereas the practical application were maybe more limited compared to other specialties. I know Mount Sinai knows a thing or two about environmental medicine. There were, given the history of the school and also the conferences that are hosted here on the Exposome. Now, so this is the story of how we came up with this. Having worked in the arena of climate and health for about 8 years, the question of clinical application of climate and health knowledge has always come up. So my colleague and I, Dr. Julie Becker, we took the experience from environmental medicine and looked at tools in that field. And there's one seminar article that defines a mnemonic on what are the questions to ask in collecting an environmental exposure history. That mnemonic is called I Prepare. And of course, every word stands for a category of questions. And then the key factors about I Prepare include prompting practitioners to ask about environmental conditions. That's one. And then the second thing is asking about the social determinants of health. So in parallel to that model, we developed the mnemonic designed to address climate factors that may exacerbate health, many of which are social determinants of health. Now, you can use your phones and look up this QR code that tells you what the mnemonic is, which is O Career, and it stands for occupation, condition or medical history, activities, residence, environmental concerns, education, and referral. Many of you recognize that there's a lot of social determinants of health references in these categories. And as I said, you can see the actual questions in close up when you go and check out this handout. So our aim is to have the clinicians familiar with these questions so they can weave them into their assessment. And then the answers will ideally provide clinically relevant information. And then also in that handout, you'll see that there is a series of ICD-10 codes. And the reason that we wanted to include the ICD-10 codes is because often ICD-10 codes would be connected with payment and reimbursement. So that in that sense, it doesn't, the ICD-10 codes don't just codify the questions, but they provide an incentive for their use. So even though, as I said, some of the ways to track health could be by using the ICD-10 codes that then the practitioners will use. And so, as I said, by kind of using these aids, we hope to increase the repertoire of tools that are available for clinicians, as well as public health professionals, to elicit histories that lead to accurate documentation, evaluation, and possible solutions. And I know that one of the posters today, we're talking about adaptation mechanisms. And so this would be a really good complement to identifying what might be done for a patient and then using those adaptation mechanisms as management. And I'll stop here for now.
So I'm Karen Solomon, and I primarily work at the New England Journal as a deputy editor. And I actually just want to point out, for those of you who are interested in reading about aspects of climate change and air pollution beyond what we're talking about today, and worker health, we actually have an ongoing fossil fuel pollution and climate change series. We have a climate change page. You can just kind of click on it and have a look at what we've done. And I think there's been some really, very excellent articles that may be helpful in practice and in subsequent research. But part of my time, I am also a primary care doc. And so I want to talk about this a little bit from that perspective. So mostly just as an overview, and I believe we're going to go into this more in our panel, but I kind of just wanted to lay out sort of three main ways that practicing docs can really help to reduce workers' climate-related health risks. And they've all been touched upon in the excellent talks earlier today, but it sounds like we can get into more practical nitty-gritty here. So I want to say, number one is obviously in talking to our patients. And we've heard a lot about, and actually your tool is quite interesting in this regard, but really taking very careful histories. So not just occupation, but then what are other factors that are going to exacerbate risks for climate-associated harms. And so again, you've heard about this, and I'm just reiterating them, for kind of practical guidance. But as we're seeing patients worrying specifically about those who are older, who have comorbidities like diabetes, hypertension, cardiovascular disease, who take any of a range of medications, who are pregnant, and as has been appropriately emphasized many times today, those who are coming from low-income communities and communities of color. And then really just taking the opportunity to inform them of risks and then what they can do to reduce risks. And those came out very nicely this morning in terms of, as possible, removing oneself from the heat, drinking adequate fluids, understanding signs of heat-related illness so they can respond to them promptly. So that's sort of the clinical care piece. One thing I would just urge in that regard is that when we're counseling patients, I think it's really helpful to throw in there, we're talking about heat because, fossil fuel generated climate change is leading to a lot more hot days. And one of the reasons I think that's really important is that there is evidence that when people hear from people they trust about climate change, it tends to make them care about the issue more and be more in favor of climate action. And obviously we need more and more people to do that. Second is education. And again, we've heard a lot about that, but I would just talk to the broad importance of incorporating these issues and specific attention to those most vulnerable in our medical school and residency curricula. That is happening more and more. And I hope we can talk a little bit about that. I know you're involved, others here are involved in that. I haven't seen as much attention personally to the occupational health component. So I think it's a really important twist that is still getting overlooked a bit when we talk about vulnerable groups. And then finally, again, has been mentioned, but I think we have a real important role in being involved in legislative and other advocacy. And you've already heard from other speakers about ways to get involved, but I want to just remind you that it can be as simple as signing on to a letter somebody else has written about a policy that is going to affect greenhouse gas emissions. If that's all you have time to do, students, for example, residents, but if people can find more time, writing sort of an individual email or calling a legislator, and that can be at the local, state, or federal level, writing op-eds or letters to the editor and weighing in from a health professional perspective. Why does this matter for people's health? It's an area that I think is really just beginning to get some of the attention it deserves in terms of legislation. And so I think we're uniquely poised to do that. And then final point on that is that I know we've talked a little bit about the decline in trust in the medical and scientific enterprise. And certainly that is a big problem, but it's interesting. I did see a very recent survey where people were again indicating which professions they trust the most. Nurses remain at the top. Engineers have now sneaked in ahead of doctors, but doctors came next, and then scientists below. So despite some falls in trust, I think we really do have a very powerful voice, and I just want to encourage people to use it. Thank you.
right after engineers, you said.
Yeah.
Yeah. All right.
Gotta get them
But
involved.
nurses are still up there. They've
They're at the
always
top.
been at the top. Ever since I've been in risk communication, nurses have been at the top. So thank you all for those comments. I wanted to start with a question to all three of you. As you said, we're going to drill down a little bit and thinking about it. And it's this, the spirit of this panel is about thinking about how it's broadly applicable across specialties. If you all could give us an example of sort of how you see climate change awareness being incorporated into some medical subspecialty. And maybe, Pune, if you're okay with it, I'll start with you, because I know with that career mnemonic, I thought maybe you had some examples of where that is being used.
Yeah, so I can give an example of that. We're gonna do it like this. Yeah, so for example, if you look at the O of the O career, which stands for occupation, some of like the occupational medicine providers in the audience might recognize how that category is really trying to get at what is a day at work like what's the picture. And so, for example, the question might not just be what do you do for work, but how do you get to work, right? Because then what you could then think about is that when there is an extreme weather event and it disrupts infrastructure, will people be able to get to work, in that scenario? And so, and as such, recognize that, as a vulnerability if that comes up. And so, so that might be, kind of an area where specifically for that specialty, it would be very helpful to do. Another example that again is in that same one is environmental concerns, and it talks about water quality. So again, like let's say if there's flooding and, I live in Philadelphia, combined sewer overflow, if there's a water quality issues, will people be able to get quality? And I really appreciated, Dr. Alexander's talk on disabilities, because, that's definitely an issue. Will people with disabilities be able to, get that? So, so those are some of the questions, that I can think of that would, bring out some of these discussions relevant to the patient's health, to client's health in case of an occupational medicine provider, and be able to, identify some management plans.
Or, so we're talking, sorry, I have to.
Yeah,
get a
application
recap
to
make sure I answer.
subspecialties and sort of how, if there's sort of specific examples that you can offer about.
Yeah. So I guess I'm super focused on access to care, I guess, because like with occupational health and everyone being a worker, I just feel like it's kind of the same discussion, but very much like how do we take care of the whole person, which a lot of their person is, what you do for work. So I think in like family medicine, which I also really highly related to emergency medicine, because these are kind of access points for care. And if someone doesn't have a PCP, then their PCP is going to be the emergency department. So I feel in these specialties, because of where we're at in time with climate change, that if we kind of look a couple steps ahead of what we might start to see, then that's a really clever thing for students and practitioners to think about. Maybe there's things that are going to come up that we haven't seen in the past. And with changes in resources, maybe people are traveling more for work. And so the questions you ask might be more related to, where have you recently traveled to, and things to consider. Or where's your main water source when you're traveling? So for example, Legionella comes to mind. It's like a waterborne bacterium that we do face a lot in the Virgin Islands, because we do our main water source is through water catchment of rainwater. So we store water in cisterns, but I could think of a lot of different occupational situations where someone may be trying to do something similar, whether it's from, we don't have enough rain, we're in a drought, or we're carrying water with us to work sites and those kinds of things, which municipal water is treated in ways that you wouldn't have that much of a worry about it. But what if you have someone who just recently traveled to someplace where there is a lot of Legionella from how you do your water catchment? What if they recently had a respiratory virus and they're presenting with pneumonia? Are you really are you going to test for Legionella? Are you going to rule that out? That's, those kind of things to think about. Or, and then another thing with that is, what are people doing at home after they go to work? So say we start having more expensive electricity, and I bring that up because there's choices about air conditioning in the islands a lot. You could have AC at night, but you might not want to pay for it that night because it's highly expensive. And so this also goes for water heaters. So just for getting to know your patient population a little bit better, getting to know what people do to kind of save a little bit of money, people turn off their water heaters sometimes. And what does that do? That changes the temperature of that sitting there water, which actually makes a perfect breeding ground for that 80 to about 115 degrees Fahrenheit for the Legionella to grow. So like, are we thinking, effectively, are we asking the right questions? Which I think the providers, it's going to be a continuous learning experience. And I think that's something that, you're in school, you hear this, that you're always going to have CEs, but I think even more now, you have to really think about how do you stay 2 steps ahead of what we might be seeing so that you catch those things as they come through.
So I'm going to give a more general answer, but I'm just thinking with respect to what's being done now in the Harvard Medical School and then the Mass General Brigham residency programs, where really there was a push by, I know there's a lot of students here, so it's generally driven by students and trainees, and then faculty get pulled along in a good way. But to really interweave climate into every aspect of what they're learning, and in a way that does not take an enormous amount of time, because there's tremendous worry on the part of administrators that if you spend too much time on it, then you take time away from something else. So I was most involved with the residency program, and they basically have just taken each area that they have lectures in. So they're hearing about asthma, they're asking the lecturer to incorporate, one slide on, heat and air pollution, so that it comes up. And for speakers who don't have that kind of information, there's been an effort to provide them a slide. And you guys may be aware, there's actually a big consortium. So it's like Columbia, Mass General Brigham, Emory, and UCSF that was sort of working together to develop slide sets. And any of you guys who are students, if you're interested, they're always looking for people from other centers. But when they do kidney disease, then they talk about heat-related, kidney problems, et cetera. So I think there are ways that people are thinking creatively about making sure that people learn this without sucking up too much time.
Are you speaking about the climate resources for
the
health
consortium,
education?
yeah.
It's the CRHE.
Yeah.
Yes, if people aren't aware of this, that's
Yeah.
right. A growing database of some really great resources
Yeah.
for that curriculum and feeding it across specialties, like you're saying, so making it relevant for everybody if they don't see that an automatic connection. But thank you all. Valerie, I had a question for you. Thinking about the context of the Virgin Islands and some of the climate-related diseases that you're seeing, that your bureau, your Department of Health is starting to sort of try to get ahead of the curve, as you alluded to, and some of the actions that are taking around that.
Yeah, and I have this one particular condition in mind that I really do want to talk about, and it's a nice example because it shows like how intricately intertwined we are, epidemiologists and clinical medicine doctors. One example is ciguatera fish poisoning, which we've talked about harmful algae blooms. Well, one of those is a microalgae that has actually increased and will continue to increase. It is also found in Florida and Hawaii and the U.S. Virgin Islands, but this particular algae has a toxin. So when fish eat it, it goes into their body, and then it kind of it actually accumulates over time. So the bigger fish and certain types of fish are more likely to have it. And then sometimes what people will do is they'll never will have heard of this. They'll catch their first barracuda, and then they're like, I'm going to eat this barracuda, and that's like one of the no fish for ciguatera. And where are they first going to present to care? Likely an emergency department. And so with this, it's really important for this reporting to happen so that epidemiologists can have a really good idea of the actual reporting, because it's usually about only 10% of the cases actually get reported to a local health department. And so it's really hard to have that surveillance data, which you have to have so that we can make our cases for different legislation, for funding for different projects. And so that close relationship and actually accurate and timely reporting can be really helpful in those situations so that we can get the news out to the community. That the fishermen, can know. Maybe there's different locations where we're starting to track more of these particular fish that we're finding. There's a whole list of the fish that can have this particular toxin. but a lot of it might be someone who just moved to a location, or it might be someone who's traveling for work and they're like, I'm gonna go catch a fish and I'm gonna boil this fish and it's gonna be great. And then they end up having something that keeps them out of work for 6 months. So there's huge impacts with that, and clinicians can have a big role, especially if they can work closely with the local health department, because the things that you can't necessarily do in a clinical setting, epidemiologists can follow up on. They can do the messaging, they can do the community-based work. And so it's actually an advantage, and it's not meant to put more work onto clinicians, but hopefully there's ways that we can make it more streamlined. And I think part of that is that relationship building. It's really nice. We're not a huge place. What we do have to split our resources across 3 different islands. But with that, I do feel that the physicians, when we call them to ask some questions, they're really receptive to us because they know that we're trying to look out for things so that they don't have to. And we can also give them tips and heads up of what we're seeing and vice versa. So that relationship is wonderful for these kind of community-based actions.
Yes, barracudas, beware.
Don't eat barracudas.
That's a board question. Hot feels cold, cold feels hot. For your students
Good
out
job,
there.
good job.
That's a board question.
Please elaborate.
Yeah, for all you students out there, ciguatera poisoning, cold feels hot and hot feels cold. So if you ever had in an emergency room and somebody comes in with that, and in fact, it's people also who travel from the islands who, then by the time, they eat it on the last day of their vacation and then they end up in the US afterwards, and then they show up to the US EDs
Or
with
they have
those
pneumonia.
symptoms, or they have pneumonia and then they show up to
Consider
ED.
Legionnaire's disease.
Yeah.
Good job. Getting those board questions down.
So Karen, I want to come to you with a question to talk more about what New England Journal of Medicine is doing. You mentioned that your involvement shepherding the series on fossil fuel pollution and climate change. But I know you're also involved in some of the original research articles and some of the clinical cases. So could you speak to that?
There we go. Okay, sure. So I would say, over the years, the journal had definitely done some, sort of climate change and air pollution work, but there has been a much greater focus placed on it at this point. And it started a couple of years ago, but actually multiple medical journals, some of you guys may have seen this, had come together before COP26, the big conference parties to talk about, environmental issues, and had all signed on, which is very rare for journals to come together to do anything. And everybody signed on to identifying climate change and the failure to try to keep global temperature rise below 1.5 as, quote, the greatest threat to public health. And we sort of signed on to that, and we were kind of talking about doing more. And it's the kind of thing where this comes out and then nothing great happens at COP. And we got, very sort of motivated to try to make it, more of a key priority of what we work on. So as part of the series, we have just a number of solicited, for the most part, a couple have come in over the transom, but review articles in different areas. So again, I don't know if you've seen, we had one on children's health. We've had one on vector-borne disease. We worked actually with so NEJM is part of something called NEJM Group. So there's a journal called Catalyst that's really focused more on health systems and health policy. And then another journal called NEJM Evidence, but we worked together. So in Evidence, there were articles on pulmonary disease, and research methods in climate change, and Catalyst did something about how healthcare systems respond to heat. And we've just been continuing to do these. We had a really nice sounding board that was completely focused on equity issues and basically low income and particularly communities of color, and really the quote climate gap and sort of differential harms, and then, disparities in ways of being able to address these issues, et cetera. So the goal is to kind of keep it at the forefront. And Perry, you mentioned cases. So, we have these clinical cases. Also, I actually do the clinical problem solving series. And so occasionally I kind of encourage those where there's a little climate twist. So it'll be a patient, we did one a while ago, a patient in an unusual area of the country presenting with alpha gal allergy. You guys, I don't know if you're familiar with this, but if you are bitten by a Lone Star tick, you can develop a meat allergy and it can present like anaphylaxis basically. not like with, okay. And so, this was a case where this patient presented with anaphylaxis, and it was just in an area where they weren't thinking of it at all. And it sort of spoke to the fact that our vectors are moving and we have to worry about diseases in different places. So I'd say we're really aiming to kind of come at this from a variety of perspectives and keep it at the forefront of people's minds. And the review articles all have a piece on action because, I think we've gotten much better at describing the problem, but sort of then pointing out what's being studied, what do we know has been successful so far, where do we need to go in terms of research and implementation. So again, I just encourage people to have a look at it.
Thank you. That's a super important platform, and it's great that you're figuring out creative ways to leverage that. Pune, I have a question for you. Thinking about the question that got asked this morning by the epidemiologist about how to use clinical data to improve our surveillance, think about climate-related conditions. And you mentioned ICD-10 codes. I wondered if you could speak a little bit more of sort of the potential there.
So maybe I'll pick up on something that Valerie had said. Again, in the handout that you'll see, there are a set of ICD-10 codes that really touch on the social determinants of health of patients. And I know that there's a lot of health systems, for example, VA health system is really focusing on using these ICD-10 codes for social determinants of health to identify risk factors within their veteran patient population. So for example, one of them is accessibility to healthcare. So like that could be a secondary code, for example, for someone that might have, and like if you recall for Hurricane Katrina, one of the most, what people got most sick about was not having access to their own medication. So this would be a really important risk factor. And there's actually a recent article that came out that outlines ICD-10 codes specifically for climate-related conditions, like flooding, et cetera. So the ones that you're seeing right now could either be used as complementary to those like secondary coding. And then if your students, medical students or, nursing students, I'm sure you'll get a ton of that when you start your clinicals. Or it could even be just used in terms of, as a preventive, during a preventive visit. So for example, again, going into the occupational medicine arena, if there's somebody's doing a pre-placement exam for, a park ranger who might have to be fighting wildfires, there's a code for exposure to air contaminants. So that could be, a code. And then, and to me, beyond that, like again, epidemiologically, there's a lot that can be done with that. In terms of, there's a lot that can be done with that. I'll just say that.
All right, so we're shortly going to transition to questions from the audience. So be thinking of them and maybe teeing up. Carla, how do you want to do that? Oh, okay.
Question came in for Dr. Valerie. And the question is, how can clinicians and epidemiologists work together to support worker health?
Really great question. And I think we touched a little bit on it just as a group, like working together for better reporting for surveillance and kind of how we do that strategically, like with ICD-10 codes that are relevant for what we're doing. But also one thing to mention is that with that close relationship, kind of that early warning system kind of between clinicians and epidemiologists, and having that, whatever maybe the clinicians are seeing, then the epidemiologists go out in the community and really take a closer look. Or if there's interventions that are happening, epidemiologists can also help look at those interventions over time to see effectiveness. That's a way to do it. But also with the nationally notifiable diseases, what you probably also hear about in school, those can actually be mandated in the state level. So say there's something that's an occupational related illness or something we really want to look out for, clinicians and epidemiologists can work together to advocate for particular conditions to be reportable conditions in a particular state or local jurisdiction. So that's a really powerful thing, things that can be decided upon based on surveillance data and what clinicians are seeing. And so I just think better communication and then being able to document this data so that it can be done through surveillance. A lot of places are also doing a lot more syndromic surveillance through computer systems and data modernization initiatives. And so having really good ways of documenting clinical encounters in a way, and then just having in the clinical chart, there's other ways that the epidemiologist can glean some of that data and really use that to detect things early on when we maybe don't know what it is yet, but a set of symptoms will tell us that there's something going on and we can look more deeply and then report back to clinicians. So it's really a connected cycle. I would hope it continues to be, and that we continue to use that.
To build on that a little bit, I know in the Virgin Islands, there's the base population of 100 to 200,000 people, but my understanding is that during the cruise season, that population can double almost. And I wondered if you, sort of building on this question from Terry about how clinicians and epidemiologists are working together in terms of both tourist and cruise ship worker health. Is there any kind of monitoring that's going on there?
So yeah, we do receive a lot of cruise ships. I know that there's a lot of agreements between the Department of Health and the cruise ships as far as like reporting of different conditions going on at the cruise ships before they're given permission to dock. We also have a lot of ships with people from many different countries who travel through for shipping. And so those workers on those ships oftentimes do present to our emergency departments for care. And so, you know, if you are working in a setting where it's a transit hub, like the Virgin Islands or other places around the United States, clinicians will have to be aware of people who might have traveled several countries just in an incubation period for reticular disease. And then that really fast reporting will help us, because there's oftentimes windows where we can only test for certain things during a certain amount of time. And if we lose that time, then we won't be able to even get an accurate diagnosis or confirm a particular type of disease. So it definitely is something relevant for us. And we are, I think, actually less than 100,000. A lot of people relocated after the storms several years ago, or people they will live half the year in USVI and live another half the year in other places. So people are very mobile, and I think that will continue with climate change and extreme weather events out of necessity, because you have to go where you're able to sustain for your kids and also have school, and other resources or health related resources. A lot of our residents travel for healthcare, and that's big. And then part of this is also the system, our health system actually takes care of a lot more than 100,000 people. Sometimes it's up to 500,000 a year based on cruise ships and flights and that kind of thing. So, and that can actually strain a health system, but a lot of the monies that are eligible for is based on our census population. But that maybe, so sometimes there's these kind of strains that different environments and health departments might see. But with that just makes us much more important that we have those stronger relationships of communication. And people will serve multiple roles. We have one of our first nurse epidemiologists in the epidemiology division, and she serves across clinics as well as an epidemiologist, and is also interested in working with our community health worker programs too. So I see more people working in different roles as they kind of overcome some of these obstacles.
Thank you. We have a question.
Dr. Miller?
Thanks, Aubrey Miller, NIH. Thanks for the great discussions. So I just got this warning from North Carolina, where NIEHS is located, which is air quality has been upgraded for health notice for North Carolina, effective tomorrow, to code red with a forecast of 151 for fine particulate matter due to smoke transported into the region from Canadian wildfires. I'll assume that New York's probably similarly affected. So there you go. So how do we begin to translate some of this information that's coming at us as health professionals to our students, to our work, to our clinician, and way we can think about capturing the effects and how we use this information more effectively? Clearly, we're seeing this, or it goes on our TVs. How do we incorporate this into our working systems?
Anybody want to talk about that?
I mean, I'm just gonna, so if you all recall, so this is very similar to, the concern that I had brought up with Dr. Rizzo from the American Lung Association. And from what I recall from what he's saying, which I, agreed with, is really, he was saying that it sounded like the message of what he was saying was that the cities need to be prepared for these extremes, and air pollution that is not as a result of anything local, but rather, because you can travel, 200 miles or more, being exposed to these other events need to be included as, an extreme event, for the cities. And so, and that really, this might have been, a question for, the city planners and the, about like what would be some of the things that we could do for for urban cities, because Philadelphia is also like that, and here it's 155 today, and like what do we do when it's that, and it's and essentially like I didn't think to bring an N95 with me, so yeah.
I was just going to add. No, and I think it's a great question. It's a challenging question. I think, my understanding is that some healthcare systems are becoming better organized in certain ways. So I'm thinking of it more particularly for heat, where I know there's an initiative now locally that is, it's more theoretic than actual, but that you would have pre-identified individuals by zip code in urban heat islands or what have you, and that you'd be reaching out in advance of, X predicted extreme temperature, and kind of providing information that alternatively they might have gotten at the doc's office, but their doc probably didn't bring it up, or they haven't been. So I guess in theory, if you had a similar system where you knew your patients with CVD and respiratory disease, and then you knew that smoke was coming, you could use it, right? Right, and reach out. But I think there needs to be enormously more work for us to be prepared to respond appropriately.
Can I ask a quick question? So we know that the fires are burning in Canada, correct? What we don't know is the proportion of attribution of those fires to climate change. So like the World Meteorologic Organization every year comes out with a report on how much of the current weather systems we're seeing and the extremes we're seeing are attributable to climate change, and they come up with clear percentages. Perhaps as a way to look forward into the research we need to do, I'm not sure it matters when you have smoke, but understanding and messaging, if we could figure out a way like they have to calculate the attribution factor to some of these health impacts that we're seeing, like today, and as a way to sort of get a handle and account for these extremes, so that we can push harder for faster and faster action, so that we don't hit 1.7 degrees, because I think we're past 1.5, as a methodology for creating action.
Did you want to say? Go ahead.
I just wanted to say something about it. So that's so I just wanted to say was that there was a really good paper about that. And what they did was that they looked at kind of what is the average air pollutant, let's say in a city, like on a day in June. And then this was during the wildfires in Southern California. And then whatever was added on top of that is what they attributed, to the wildfires. And the outcome of that paper was that, and I know that there are, air modelers sitting in the audience, so I'm sure, this is like something, and that the ultrafine from the wildfire was worse for health than the ultrafine of an urban environment. So that it makes it even that much more relevant, for healthcare. Yeah.
We have a question from our online audience. Are any of you, or are you aware of anyone doing healthcare research and disparity awareness work with workers in the field of environmental conservation? So thinking about field biologists, park rangers, outdoor educators, thinking about how they deal directly with climate change, and are often the lowest paid workers of people with higher education. Any comments on that?
Good question. I don't know the answer.
Okay. And if there's anybody from the audience who would like to comment on that, you're welcome to go to the mic. I have another question from online. How should or can community health workers work with healthcare providers to support communities with inequitable access, particularly as it relates to social determinants of health. Really, the role of community health workers with interfacing with the healthcare system.
I'm sure we all have something to say about this.
Yeah, go ahead. You can start. You want to start?
Okay, sure. So one thing I think about with worker health is, when can workers actually access care? And one of our goals, especially when we're looking at, chronic conditions that may be exacerbated by climate, how do we catch things early, and how do we make sure that we can go ahead and make early interventions to decrease like end stage kind of diseases? And one way that I think community health workers are really wonderful is that they don't have to just be attached to maybe just like outside the health department. They could be in mobile units. They could be connecting with faith communities, which is something that some of the nurses at VI are doing right now, is like looking at who are the faith communities that we have and how do we best access? Because back during the pandemic, which I'll just refer to that because that's something that was recently affecting us, is that people would look to their faith-based organization leaders. And then these leaders are the ones who are going to say, these are our top 5 conditions that we face in our particular community. And so community health workers working with epidemiologists, working with clinicians could be a huge part of that screening and that access to care, because a lot of times people will wait until an end stage condition has occurred or symptoms of an end stage condition when there's so many things that could have happened along the way so that someone could remain healthy and could receive access. But it's not going to be during like regular clinic hours or in typical clinic settings. We need to be able to have the access to care actually be more agile and coming from people that are trusted by the community, who understand the community and get the day-to-day struggles, because those people who can actually understand what workers are facing will be more listened to, and then that makes all the difference, I think, in someone giving metformin a try for the first time when they're like, I don't ever want to take a pill. It's like, well, maybe this pill now saves you 5 pills later. But those kind of discussions have to happen one-on-one, and they have to happen in settings that are agreeable to the community members or workers.
All I was going to add is I agree it's critically important, and particularly as it kind of seems harder and harder to access, even where there are health centers more readily accessed. It's just that it's kind of harder to get appointments. It's harder to get there. It's harder to get in. So I think that sort of link to the community is really important. But one other point related to this is I would just encourage, again, this is sort of students and people who want to get involved in advocacy. Even if you're not, generally working out in the community, I think there is enormous benefit in actually, getting to know frontline community organizations, because you just learn an enormous amount from them of what they're experiencing that you don't see on the other end when you're sitting in your office. And it really sets you up, I think, very well to then in advocacy, really to be amplifying the voices of the people who are disproportionately affected, as opposed to focusing on what, in your own head might have seemed the most important. So it's just another piece of fixing this problem.
Can we stay with that for just a minute, just to think about advocacy, because you wear a lot of different advocacy hats across different, there's sort of through the hospital, you're doing climate action council within the medical school on a faculty council, but then also in the community, with a divestment group at Harvard. And then you helped found the Climate Code Blue, which is a community position.
It's docs in the area.
So just maybe sort of bridging from what you were just saying into that, work that you do.
Yeah, no. So I was going to say, so one piece of what I do is just with colleagues in the Boston area, we had come together. We were all like pretty, panicked and frustrated about climate change. And we came together and really thought that what we could probably do most usefully is to really try to partner with community groups and understand what was going on. And then, our advocacy is sort of based in that. So, at this point, I would say we do a lot of, testifying and letter writing and calling about, again, legislation that is gonna, would especially benefit low-income communities or communities of color, or could potentially fossil fuel infrastructure that is going to be especially harmful to those individuals. And, I was going to say one piece, which we've done a little of, and I'm going to throw it out there because we didn't talk about this kind of advocacy, but is the, take to the streets advocacy, because I honestly do think a lot more of us need to move in that direction. And, a white coat out at, a protest, it's kind of powerful. I'm not sure, I can't promise you it makes, an enormously greater difference, but I think it is like empowering to communities that are working on these issues. And it does, kind of catch the eye of legislators when docs who are just really worried about health and children's health and what have you are like out there and with others. So. Want to add?
Yeah, well, you do a lot of work with PSR, as you mentioned, and yeah.
Yes. So to speak to that point, for example, I definitely emphasize getting involved with grassroots organizations, nonprofits. Often, I volunteer with Physicians for Social Responsibility Pennsylvania, and this project came out of them supporting, where none of kind of places where I actually get paid for really. I had the venue for that. So I definitely encourage, people to do that. So that's one thing. And then also, often you can like testify, on behalf of that organization, again, in a way that it might not be possible, from like an academic institution. That's one thing I wanted to say. The second thing, I'm going to just quickly maybe add something to the last question, which is that we spoke about cities' readiness or places' readinesses in face of climate-related events. But one area that I think is really important to highlight is the readiness of healthcare systems. So when a lot of these kind of extreme weather events happen, like let's say wildfires, the places that people were going to were emergency departments, or for flooding, when there's like exacerbation of these medical conditions, they have to get hospitalized, right? We saw that in COVID. And so speaking to kind of the frontline workers, the healthcare workers who are on the front line of that would definitely be kind of also feeling the brunt of, a lot of these things if healthcare systems are not ready to really take on, some of these challenges. So I just wanted to maybe just identify that.
Thank you. Thanks for that point. Valerie, you used to serve as an epidemic intelligence service officer. And I know that typically my understanding of the model is that they have to be invited in. So it's a service provided by the CDC, but you have to be invited in by the local municipality to investigate outbreaks typically, right?
Yeah, like
kind of have that right?
Yeah, for EIS, it's a 2-year fellowship training program. So, but yes, in general, federal entities must be invited in to any sort of state, territorial, or local jurisdiction to do work.
Is there precedent or opportunity to sort of be invited in to do climate-related outbreaks? Do you see any kind of potential? Are there examples of where that's already happening, or do you see potential where EIS or the infrastructure of CDC investigating outbreaks could be better leveraged around climate and health?
Well, I feel like everyone's already been talking today about some of the infectious diseases that are already going to be probably augmented by climate. I think emergency response may be a large part of this related to extreme weather events. So EIS officers do deploy as well. So in the program, there's a lot of headquarters-based officers as well as state-based officers. And so they'll spend 2 years either at a state or local health department or 2 years at a headquarters for CDC, including NIEHS. And from there, they can be deployed to different jurisdictions. And then, and some of it is related to emergency response. And so it could be health-related effects related for flooding or for a storm. So that's definitely a possibility for EIS officers, as well as I know CDC does deploy based on jurisdictions and requesting assistance. So it could be technical assistance for understanding a particular hazard. It could be technical assistance related to trying to understand a current level of disease. So one example is when I was serving as EIS, we wanted to determine how many children had been affected by dengue virus in the past, which is something that right now it's Florida, USVI, Puerto Rico, and some of the other related islands that have had a burden of dengue, but now just earlier this year, the MMWR, I think it was volume 11 of this year, Arizona had their first documented case of locally acquired dengue infection. And so when we did this work in USVI, it was to determine if we had a particular level of dengue virus that the children have contracted in the past, to see if we were eligible for having one of the new dengue vaccines implemented. So we also wanted to just know how many children have been infected before, because you might know that the first infection isn't necessarily the highest risk, but that second infection, which you can catch dengue up to 4 times, because there's 4 types, you can catch each type, but that second infection raises your risk of that hemorrhagic dengue. So we wanted to understand how many people were affected. So we did have many EIS officers that came to USVI to work on the study. It was 15 different schools. And then at the end, we did find that, and it was in the MMWR earlier this year, that we found estimated about half of the children who were in that age group had contracted dengue virus at least once, based on the IgG antibodies that we found. But within this program, we also had an educational component, which was huge, because we wanted, sometimes you do the findings and do the study, and then you think about an intervention, but we wanted to take the opportunity to also provide as much education as possible at the time. And so, and that was a huge effort and a big invitation, but it was nice to be able to do kind of the educational intervention at the time of the collection of information, so that if nothing further happens, then there's still been awareness around it. But then, looking at Arizona, what's next for them? With having this first documented case, who knows what comes next? And but it's a wonderful health department that they have there, and I'm definitely a fan of their work. And they're another place that they're going to see a lot more climate-related conditions. So I think it's very possible, because a lot of the things we already face, chronic diseases, infectious diseases, emergency preparedness, all can be changed with what we see with extreme weather events and temperature changes.
Yeah, thank you.
So it's across the board.
Right. It sounds like, and there's, thank you. It sounds like EIS is already doing a lot of work in that space, and there's, you expanded my understanding of even sort of what the machinery of EIS can do, and sort of tackle projects to amplify awareness, and like you said, bring in an intervention at the same time.
Clinicians, it's MDs with MPHs, it's nurses with public health experience or research degrees. There's also pharmacists, there's psychiatrists, people working in psychology, people who've done social work, like MSWs, so, and veterinarians as well. So it's a wide variety of clinicians and scientists who are eligible for the program. And it's pretty much a postdoc. It's a postdoctoral training to understand epidemiology a lot better, and how to do applied epidemiology in the field.
Yeah, and like you said, they're not all based in Atlanta, even though it's CDC run, right?
Correct. And then NIEHS, there's NIEHS in Morgantown, West Virginia, as well as Cincinnati. And then there's also other programs like the Public Health Associate Program, the PHAP program, which is more aimed for like master's and bachelor's level. But that's another way to get involved in like state and local governments for training in epidemiology. And then the Council of State and Territorial Epidemiologists also has a couple of different programs on applied epidemiology fellowship and applied public health informatics fellowship. So lots of different ways to get this hands-on experience. And a lot of it probably will be at least somewhat climate related, because I think a lot of our public health will be affected by extreme weather events.
Thank you. Yes. And you just threw out a lot of different options. So please
trying to,
follow up
like,
with
let them
Valerie
know
if there's
all the
if people
things to
are
look forward
specifically
to.
interested in any of those programs. Those are excellent opportunities. I think we find ourselves at the end of time. Thank you very much for your participation in the panel.
Before we get to the poster awards, I want to take this opportunity to thank everyone for tuning in or being with us in person today. And I hope you have been inspired by the talks we've heard today. And more importantly, I hope you have new tools in your toolkit to support your patient and communities. I also want to take this opportunity to thank the many staff and volunteers who worked on this program, especially Carla Azar. Thank you, Carla. Hannah Choi, Allison Devia. Lunch was so graciously put together by Giselle Candelario, Valeria Mendez Rosa, Aviad Sadat, and Andrea King Valerio. I also want to thank at this time the poster judges, which were Emily Sinai, Dr. Sarah Evans, and Dr. Karen Solomon. Also, I want to remind everyone, please complete the evaluation surveys. They mean a lot, they give us a lot of information, and they will provide an opportunity for us to improve and on the next climate change conference. Dr. Sinai is laughing at me. Okay. There's a QR code on your program or a link in the chat. Before you leave, please recycle your name badges on the table out there at the exit. Okay. At this time, we're going to announce the winners and the virtual winners, and everyone will receive their plaques. However, because of virtual winners and not being here, we are going to recognize everyone and your plaque will be sent to you. Okay. First, third place goes to a virtual participant, Yasmin Mihat. Yasmin is a student at the University of California, Berkeley, and the title of their plaque was Impacts of Wildfires on California Radiation Oncology Clinics. Let's give Zaat a hand. Second place winner, Dr. Mike Heath, postdoctoral fellow in environmental medicine and public health here at Mount Sinai. And Dr. Heath's poster was entitled Associations Between Nitrogen Dioxide and Routine Vaccine Antibody Levels in Children. Would you stand, Dr. Heath? And first place was difficult, and it is actually being shared by two of our virtual participants who are also collaborators. Alexander Conway is a medical student at the Icahn School of Medicine at Dartmouth, and his title was, her title, please excuse me, Reducing the Environmental Impact of Healthcare Conferences, a Study of Emissions. And Ali Sabah is a postdoctoral fellow and MD, and he is at the University of California, San Francisco, and the title of his poster was Network Greener, Sustainability for Conferences Made Easy. Okay, let's give him a hand. And now I'd like to just tell you how happy I am that everyone attended. Thank you so very much. Have a safe ride back to your places. And again, thank you very much for attending.